CME from IMA HQ, that is IMA National IMA. This was for decoding cough and fever clinic. So these were the faculty, Dr. Samrat Shah and Dr. Khadge madam. Again, we do have webinars as well. So those who cannot attend physical CMEs can always attend webinars, but we encourage nowadays to have physical CMEs so that there can be interactive sessions. So these webinars are every month. Webinars are usually for 1 MMC points, while our CMEs are for 2 MMC points. On 30th April, we conducted national level examination for fellowship program of CGP, College of General Practitioners. Pune branch of IMA has received the best branch award from National CGP. And second time this opportunity was given to us to conduct this exam. And IMA Pune is also now selected as the study center for CGP. Just day before yesterday, on 12th May, for the International Nurses Day, this was a beautiful program organized here in IMA, Vandana Tuja Paricharika. We felicitated almost 75 nurses from various hospitals, especially hospitals of HBI, Hospital Board of India, Pune chapter. They participated. The nurses from these hospitals were felicitated, along with nurses from Pune Municipal Corporation. And we did free hemoglobin checkup and bone density tests for these. They were given some health tips and also a talk on osteoporosis. So this was well attended. So a few things about upcoming CMEs. Of course, today's you all know, and we are very eager to listen to all the talks, and thank you for joining for this. We are also starting online certificate course on hypertension from 17th May, which is a World Hypertension Day. It's an 8-module course. Even today the registration is going on and you can do the registration. Today those who are attending, we are giving special discount, so the fees would be only 8,000 and not 10,000 as mentioned in the brochure. So this is 8 MMC points certificate course. After the course attended, you will have to give an exit exam. The exam will also be online. So all the modules are online, exam also online, and then you will get the certificate. All work and no play makes Jack a dull man. So here we have leather ball cricket tournament, which will be on 26th, 27th and 28th of May this month. Then IMA Pune celebrates Foundation Day on 31st of May. So the whole week we have some celebrations. So as I mentioned, 28th May there will be finals of cricket match and the award function. Then we have an Atsugao Anande where we have invited special children from Kamayani and their Kalavishkar is kept over here. I request all of you to join for this to encourage these children and their parents. On 31st May, we have a special stand-up comedy by IMA member Dr. Sanjeev Kumar Patil, who is a well-known Marathi film and television actor. Bole to tension nahi lene ka. Then we have on 4th of June a painting workshop. This is a very interesting thing. It's a 2-hour workshop by Dr. Maya Bhalera. And she is going to teach us. And everyone will create one beautiful art within 2 hours. So please join for this. This is at 10 o'clock in the morning. And in the evening we have Kalavishkar by our own members. I am an artist, I am artist. This is by IMA Pune Art Circle. So let me now request you to come for these Foundation Day celebrations. Upcoming academic activities on 24th May, there will be a webinar on diabetes and cardiology for 1 MMC point. On 13th June, there will be free health checkup camp for वारकरीज. इकडे दिंडी येते, तर वारकऱ्यांसाठी IMAच्या premises मध्ये free camp असेल. On 18th June, we have a CME on newer horizons in medical services with 2 MMC points. Let me announce today those who have registered for today's CME, this CME will be complimentary for them. So just tell your names down at the registration counter so you can attend this CME complimentary. This is about our magazine IMA Plus. Again and again I request all of you, this is our magazine, members magazine. So do send articles, interesting cases, poetry, whatever you want for this, and we'll publish that. If you want to join IMA, you must join IMA. So it is the new membership. Please fill the form and sign at 2 places. It's a very, very easy process. And we have a special team for membership drive. Dr. Virendra Ostwal will help you for this. So life membership now is single 18,526 and 27,792. But presently there is a discount going on. So you must take the advantage of the discount scheme. So please contact any of the office bearers or Dr. Virendra Ostwal, and he will help you to get the life membership at a discounted price. Thank you very much. May I now request our President Dr. Raju Variani sir to come and welcome all the guests.
Thank you, Dr. Geetanjali ma'am. A very good morning to all of you and happy Mother's Day. We welcome you all for this CME on GI Conclave. IMA Pune, the membership is 5,000, but we are facing, the hospitals are facing many issues. Like recently there was one incident of the brutal killing of the intern at Kerala. So we have to face the challenges. Medical practice, medical profession is facing many challenges. We have to fight these challenges together. So we have to unite to rejuvenate the healthcare. So we have to increase our membership also. Those who are not yet members of IMA should become members of IMA. We have to unite, we have to show the numbers. And IMA has now, till 5th of July, there is a discounted membership fees. There is a discount of 25% till 5th of July. So those who are not yet members, please become members. As far as today's CME convener, Dr. Dadasaheb Maindad, has taken great efforts since last couple of months. He has crafted the topics so very nicely, and there is a great number of speakers, excellent talks, very nicely crafted CME by Dr. I must appreciate Dr. Dadasaheb Maindad for this wonderful GI conclave. Thank you.
May I now request Dr. Dadasaheb Maindad on the dais, please. He'll give the overview of today's program.
Good morning, doctors. Thanks all of you, as you given your precious time on Sunday morning, and you are here for our GI conclave. And we are formulated a very good program which is covering whole gastroenterology, in which all part of the gastroenterology are covered. We are covering in liver, there is a decompensated liver disease, non-alcoholic fatty liver disease, GI bleeds, and in intestine related topics. Also we are covering small bowel as well as large bowel diseases like IBS, IBD, and in small bowel evaluation. We are not forgotten to take care of advance in the gastroenterology, and we also included advanced endotherapy and endoscopy updates in our this today's program. So thanks, I will not take much time, and thanks all delegates who are here in early morning. Thank you.
So without taking much time, we'll start the first session. To chair the session, may I request Dr. Nagpal sir, who is head of the Department of Gastroenterology, Bharati Vidyapeeth Hospital, Pune. Sir, please. Yes, thank you, sir. Dr. Ostwal, sir, Aniket Ostwal. Sir, please be on the dais. Dr. Vrishali Wagh, madam, the consultant rheumatologist. Is she here? Yes. Dr. Shinde, sir, Dr. Kiran Shinde. Nahi aale. Okay. Thank you. A very good morning to all of you. And let me now take the privilege to introduce our first speaker, Dr. Rahul Talele, sir. He has done, Dr. Sir, please come on to the dais. He has done his MD in Internal Medicine and DMD in Medical Gastroenterology from Asian Institute of Gastroenterology, Hyderabad. He has done his fellowship in Advanced Endoscopy and Endoscopic Ultrasound from Mirror, and fellowship in Third Space Endoscopy from WCMU, China. He is an ex-consultant as Asian Institute of Gastroenterology. His areas of expertise are mainly ERCP, EUS, that is endoscopic ultrasound, and he has many national and international publications. Thank you for joining, and let's hear to you.
Good morning. Myself, Dr. Rahul Talele, and to start this topic, I'll just like to say a few things. These are very interesting times for gastroenterology. There are new innovations being discovered every day. There are new methods, new techniques, new advances, and that at these very exciting times, why I have chosen this so boring, so mundane topic to start with, that is called as irritable bowel syndrome. शाळेत असताना एक सुभाषित शिकवलं जायचं अतिपरिचयात अवज्ञा. त्याला लिटरल जर आपण ट्रान्सलेट केलं इंग्लिशमध्ये तर मिनिंग इज एक्सेसिव्ह फॅमिलिअरिटी ब्रीड्स कंटेम्प्ट. एखादी गोष्ट जेव्हा फार परिचयाची होऊन जाते तेव्हा आपण त्याच्याकडे दुर्लक्ष करायला चालू करतो, आणि ॲज अ डॉक्टर वेन वी स्टार्ट टू डू दॅट, it may end up delivering a suboptimal care to the patient. And when the disease is so common, I thought, why not just take a few minutes of our time and revise what is going on, what is new, and what should we be doing in this common disease of irritable bowel syndrome. So this is the outline of my talk. We'll be having a brief introduction to pathophysiology, diagnosis, ROM4 criteria, and management. So irritable bowel syndrome is one of the most common GI disorders. It is characterized by chronic recurrent abdominal pain related to change in the bowel habit or defecation frequency. It is commonly accompanied by anxiety and depression, and it is at present, overall, if the world we consider, at least 10% of the world population is being affected by irritable bowel syndrome. So demographics of the IBS, we differ from the West. So what are the differences in this disease when we are comparing Western countries with India? So prevalence in Western countries is around 10 to 20%. Prevalence in India is less, 4.2 to 7.9 in few of the major cities studied. In West, females, the disease is observed more commonly. In India, somehow, I don't know, but the data says males are more frequently affected. It is more common in the young. Again, one important difference is in the Western population, the lower abdominal symptoms are predominant, whereas when we study the Indian population, the upper abdominal symptoms are more common in irritable bowel syndrome. So again, coming to India, if we consider the total overall functional GI disorders, the incidence is 26.9%. So every 1 in 4 persons is affected by some or the other functional GI disorder. Most common in India is functional dyspepsia, that is 15.2%. And second common is irritable bowel syndrome, 6.2%. And then there is an overlap. So in India, what we observe is around 10% of these patients, the most common overlap is functional dyspepsia with IBS. So that is why the upper abdominal symptoms are more. And in multivariate analysis, independent predictors for FGIDs are female gender, medical students or medical related professions, non-vegetarian diet, junk foods, tea, coffee, excessive consumptions, poor physical activity, anxiety and insomnia. So coming to the pathophysiology, so there are various theories. There is no single particular cause for the IBS. The theories are gut microbiome dysbiosis, visceral hypersensitivity, intestinal mucosal immune activation, dietary intolerances to specific foods, increased intestinal permeability, that is what is calling is leaky gut syndrome nowadays, abnormal gut-brain interaction, and low-grade inflammations of the intestines. So this is a new concept that is being pushed forward since last many years, that IBS is a bidirectional altered communication between the gut and the brain. So this visceral hypersensitivity of the gut, motor dysfunctions, altered barrier function, low-grade inflammation, infections, they are perceived, and there is an altered processing of the stimulus from the gut, hypervigilance, impaired HPA axis, comorbid anxiety, depression and stress. So this interaction, gut-brain interaction, it determines how the disease, how the symptoms will be, the severity of the symptoms, the treatment response, the healthcare use and health-related quality of the life. There is an interaction between brain and gut, the central nervous system and enteric nervous system, and that in turn results into altered motility of the guts. The guts are more sensitive, that is visceral hypersensitivity and inflammation. So IBS often coexist with psychiatric disorders and anxiety disorders. The prevalence is from 54 to 94%. The anxiety disorders are most common. Up to 61% of IBS patients may have coexistent anxiety. Depression is second most commonly observed psychiatric disorders in the IBS patients. Sorry, typo. And anxiety and depression symptomatology should be systemically checked and treated in IBS patient, as these factors are important moderators of symptom severity, symptom persistence, decisions to seek treatment and response to the treatment. So if we analyze them by the subtypes, if you see the mixed type of IBS where the patient has both constipation and diarrhea, they are the most likely ones to be affected by the psychiatric disorders. Second most common would be the IBS diarrhea ones, and the third most common is IBS constipation. Whereas a patient when can't be classified into a diarrhea or mixed or a constipation types, the association of psychiatric illness is found to be as equal to the general population. So clinical features of IBS symptoms include bloating, abnormal stool form, abnormal stool frequency, straining at defecation, urgency, feeling of incomplete evacuation, and passage of mucus per rectum. Non-colonic symptoms, dyspepsia. 42 to 87% of the patients report some dyspeptic symptoms, nausea and heartburn. Non-GI symptoms include lethargy, backache, headache, urinary symptoms, dyspareunia in women, insomnia, and low tolerance to medications. Behavioral features include symptoms which are present more than 6 months. Stress is often aggravating the symptoms. Frequent consultations for non-GI related issues. History of previous medically unexplained symptoms. Aggravation of the symptoms after the meals and associated anxiety and depression. So what are the red flag signs? What are the points against the diagnosis of IBS? These are the issues when the diagnosis of IBS should be questioned. If the patient has anemia, celiac disease or colon cancer has to be suspected, family history of colorectal cancer, inflammatory bowel disease or celiac disease, these are genetically related disease. So chances of inheritance would be higher. Nocturnal diarrhea that awakens the patient is the most important, one of the most important point in history that you ask the patient. A patient with irritable bowel syndrome will most likely never have a nocturnal diarrhea. Onset, if the disease onset is after 50 years of age, recent multiple antibiotics use, they may predispose the patient to the Clostridium difficile colitis. Rectal bleedings, weight loss, persistent frequent diarrhea, persistent bloating and diarrhea unresponsive to dietary intervention. So these are the some red flag signs where the diagnosis of IBS should be questioned if the patient has these signs or symptoms. So diagnosis of IBS, the newer Rome 4 criteria have been coming, and according to these criteria, recurrent abdominal pain on average at least 1 day per week in last 3 months associated with 2 or more following criteria, that is the pain is related to defecation, associated with the change in the frequency of the stool, and associated with the change in the form of the stool, and these symptoms should be present there since more than last 6 months. So if a patient is fulfilling these criteria, they can be classified to have to be having an irritable bowel syndrome. Again, this is a Western criteria. For Indian population, these criteria can't be stringently applied. But if the patient is having persistent abdominal pain which is related to defecation, whereas there has been alteration in the form and frequency since last 6 months, he can be safely classified in our settings as a person who is having an IBS. Again, to sub-classify, this is a Bristol stool chart where the stool types have been classified from type 1 to type 7. The type 1 has been a very hard constipation kind of stool. Type 7 is a complete watery, no solid pieces. So a patient is said to be having an irritable bowel syndrome, constipation predominant type, if he is having hard lumpy type 1 to type 2 stools in more than 25% of the occasions. If he has type 6 or 7 type of stool, that is liquid or watery stools in more than 25% of the time, and hard and lumpy stool less than 25% of the time, so he can be classified into the diarrhea subgroup. And mixed is where there is both intermittently hard and lumpy stool and loose and watery stools. So workup for IBS. Earlier it was believed to be patient used to be worked out thoroughly for diagnosis of IBS. It was called as a diagnosis of exclusion, which commonly meant you have to rule out all other diseases. But since the prevalence has been very high, there has been reduction in the number of tests, and newer guidelines that are coming in, they are advocating less and less tests while diagnosing the IBS. So the common flow chart would be a patient meeting Rome 4 criteria and does not have an alarm feature should get a limited number of laboratory tests, and if those tests are negative, it should be subclassified into IBS subtypes. So what are those tests which should be done? Again, there have been biomarkers for the IBS diagnosis and treatment. If we see those biomarkers, they are now many of them are yet in the research stage, yet to become into the guidelines. But I would like to draw your attention to the fecal biomarkers, calprotectin, fecal short chain fatty acids. These, if you see the chart, they have 93% sensitivity and 94% specificity if used. So these are now being advocated to diagnose IBS and rule out other diseases of the large bowel. So one of them is fecal calprotectin. The relevance of fecal calprotectin in the correlation of its level in the stool sample, it correlates with the degrees of GI inflammation. It's a marker of GI inflammation. It also correlates very well with the endoscopic criteria of bowel inflammation. The clinical utility lies is it's easier, just a stool sample has to be given. It's much cheaper than a colonoscopy. Therapeutic effectiveness is proven. We use this very often to monitor the response to the therapy of IBD. So if the calprotectins are normal, it is safe to assume that there is no major structural disorder in the colon. And newer studies, there has been just one issue, that for IBD we have clear-cut cutoff limits. So for us, IBD less than 50 calprotectin indicates there shouldn't be an IBD, but there is one debate that if you can cut down the cutoff limits lower, the IBDs could be diagnosed at a very early stage. So newer studies are trying to find out the relevant cutoff for fecal calprotectin levels that can with great certainty distinguish IBS from IBD. Yet this area needs to be explored. But for all practical purposes, a fecal calprotectin level between 5 to 10 safely rules out anything serious in the bowel. So measurement of calprotectin levels should be included in the IBS diagnostic algorithm, and it should be chosen to monitor therapeutic response to IBS patients, exclude the diagnosis of IBD, and to minimize unnecessary invasive procedures. Other diagnostic workup for IBS includes laboratory testing that we have already shown. There is no single definitive diagnostic laboratory test. The purpose of the laboratory testing is primarily to exclude an alternative diagnosis. So all patients with suspected IBS do a complete blood count, rule out anemia. Again, the following point that I have taken from the Western literature, but calprotectin or lactoferrin, stool testing for giardia, they are common in US, they have been observing this. In India, it's not very common, so better to be eliminated. Serologic testing for celiac disease, again, it depends where you are staying. If you are staying in North India where the incidence of celiac disease is very high, a serologic testing for celiac disease would be explainable. But we are staying in the southern part of the country where the incidence of celiac disease is not very high. We can ask the history. If there is a specific history suggestive of celiac disease, patient is having anemia, diarrhea and intolerance to gluten, then a serologic testing for celiac disease can also be ordered. And C-reactive protein levels, if the fecal calprotectin or lactoferrin can't be performed or not available. Other tests, again a limited number of studies, age appropriate colorectal screening if the patient is more than 50 or 40 years of age. IBS patient with constipation, simple X-ray abdomen for stool accumulation and determine the severity. Many times the fecal leaks or stool accumulation is is there, so we can give immediate measures. Anorectal manometry and balloon expulsion testing to rule out dyssynergic defecation. This is particularly important. If the patient is taking too much time on the toilet seat, he is likely to have a pelvic floor dyssynergia. The importance of this is these patients don't usually respond to routine laxatives. The response is very poor. So if a patient is not responding to the routine laxatives, anorectal manometry or balloon expulsion testing should be done to diagnose pelvic floor dyssynergia, and additional evaluation based on the presence of alarm features. So coming to the management of IBS, initial therapy, most important part, counseling. So first, when the patient is coming into the OPD, address the patient concerns. Most of the time they are concerned about any serious cause of their symptoms. Time should be taken to explain the disease to the patient, and most of them would have some phobia, most likely cancer-related cancer phobia. Do I have anything serious? So that phobias need to be particularly addressed. Assessing most troublesome symptoms of the patient and how it is affecting day-to-day life of the patient. Giving plausible cause and explanation for the disease. Many times they are asking why this is occurring and what is the exact etiology. Many times, and for IBS we don't have an answer, but a comparison can be drawn to a baby colic. When a baby is having colic, they are having some digestive difficulties, but no appreciable cause. They can relate to that, and stress or some other causes can also be given to explain their disease to them. Education and reassurance. So dietary modifications in IBS. First, if the patient is having a lot of gas or bloating, we should ask them to exclude the foods that cause flatulence. Then examples are beans, onions, carrots, bananas, apricot, prune, alcohol and caffeine. We should ask them to avoid smoking. And we should explain that underlying visceral hypersensitivity creates an exaggerated discomfort after consumption of these kind of foods. So for a patient who is having predominant gas symptoms, these food items should be asked to be avoided. Lactose avoidance, a hydrogen breath test is there already to diagnose lactose intolerance. But some of these patients, despite having a breath test negative, they say that they are having difficulties when they are taking lactose-rich foods. So they should be placed on a lactose-restricted diet. If they are diagnosed positive, they should be placed on a lactose-restricted diet. If they are not positive, an empirical trial of lactose-free diet in all patients who complain of persistent abdominal despite exclusion of gas-producing foods should be given. Many patients say they are intolerant to milk, let us say cow milk. They can be asked to take buffalo milk. Many times that works. So changing the milk types, almond, soya or milk from another mammal may help. Low FODMAP diet. This is most extensively studied diet in the IBS, and the benefits are well documented. So FODMAP is a diet low in fermentable oligo, di and monosaccharides and polymers. So these are basically short chain carbohydrates which are poorly absorbed, and these are osmotically active in the intestine lumen where they are rapidly fermented, and this fermentation results in abdominal bloating and pain. So these food products, when avoided, can give great relief to the patient. And when I say avoid, you don't have to tell them you will have to avoid them completely throughout the life. So the roadmap is you ask them to avoid all the high FODMAP for the diet for 6 to 8 weeks. And when the symptoms are under control using medications and other therapies, a gradual reintroduction of the foods can be done to determine intolerance to specific food items. This way they would be coming to know which are the food items which give them maximum problems, and then these particular items could be avoided. The problem with low FODMAP diet is it's again come from the West, and Indian food items haven't been classified into low FODMAP and high FODMAP particularly. Also, our foods are very complex, and it's very troublesome to give them an appropriate chart. But last night when I was searching, there are now a lot of online charts. There are a lot of online dietitians which are willing to prepare a chart for a small amount of money. And if possible, these patients for a low FODMAP diet should be referred to a dietitian, or many online platforms are available for giving these kind of dietary advices. Important physical activity. Physical activity should be advised in all patients with IBS. In the randomized control trial, 20 to 60 minutes of moderate to vigorous activity up to 5 days a week. A clinical improvement in the severity of IBS symptoms, that is 43 versus 26%. and less likely to have worsening of existing their symptoms, 8 versus 23%. So these percentages are roughly comparable to a single drug. So physical activity is very important and it should be advised to all the patients. So coming to the pharmacotherapy, so treatment of IBS is symptomatic and most of the drugs, they do have at least 70% of the contribution is a placebo effect. But few of the drug classes, they have been shown to demonstrate global symptom relief. They affect all the parameters, they affect the pain, the psychological and overall all the global symptom relief, what we call them. And these include anxiolytics, soluble fibers, rifaximin and antispasmodics like mebeverine. So treating constipation predominant IBS, the first step would be to ask them to increase dietary fibers, adding a soluble fiber like isabgula husk to their treatment. Insoluble fibers like rice bran worsen the flatulence, so insoluble fibers should be avoided. And if they are not responding to this primary therapy, then second line is polyethylene glycol 17 to 34 grams dissolved in water. Then lubiprostone, which is available in India, 24 grams. Earlier, the recommended dose is 8 mg twice daily, but we have a 24 mg once daily. 8 mg has been discontinued, so 24 mg once daily. Linaclotide, lecanide, tenapanor, and tegaserol, they are not very widely available and not very widely used, but still they may be coming in a few days. Treating IBS, diarrhea predominant, loperamide, 2 mg. They should be asked to take 45 minutes before a meal to control the gastrocolic reflux. Many patients complain of gastrocolic reflux. They have to go to the motions immediately after taking food. So if a loperamide 2 mg is asked to be taken 45 minutes before a meal, those symptoms can be very well controlled. If the diarrhea is persistent with antidiarrheals, then there are lesser used modalities like bile acid sequestrants like cholestyramine. But the use is controversial and the side effects are severe. Cholestyramine, nearly 30% of the patient can't tolerate cholestyramine. 5-HT3 receptor antagonist allosatron, which has been shown to be beneficial in the randomized control trial. We don't have allosatron that commonly available, but what we are using is a ramosatron, which is available by the brand name Ibisec. I personally have been using it and gives wonderful results. Eluxadolin is a mu receptor agonist and delta receptor antagonist, not available, but modest efficiency whenever it should be used in highly selected resistant cases because the side effects include pancreatitis, severe pancreatitis. Antispasmodics are considered as a first-line agents in management of IBS and they offer prompt and symptomatic relief. Most commonly used is mebeverine, is a musculotropic agent that has antispasmodic activity and regulatory effects on the bowel function. So routine dose available is 135 mg, sustained release tablets, or it has shown no typical anticholinergic side effects such as dry mouth, blurred vision or impaired micturition. And it is very well tolerated with no significant adverse effect. Fixed drug combinations of mebeverine and chlordiazepoxide are very popular. They have been approved by FDA and DGCI for treatment of IBS, and since they are a fixed drug combination, it improves the adherence to the treatment and treatment outcomes in IBS patients. Anxiolytics and antidepressant, important part is they have analgesic properties independent of their mood improving effects. So it's not just we are giving them for psychological reasons, they have some analgesic properties as well. Tricyclic antidepressants via their anticholinergic properties slow intestinal transit time, which may provide benefit in diarrhea predominant patients. So tricyclic antidepressant whenever a diarrhea predominant patient is there to be started, but at the same time they have to be used cautiously when the patient has a constipation predominant IBS. Amitriptyline, nortriptyline, deciparamine and imipramine can be started at a dose of 10 to 25 mg at bedtime. One important point is due to delayed action of these antidepressants, 3 to 4 weeks of therapy at least should be given before escalating the dose or switching to some other agents. They should at least take this medication for 3 to 4 weeks to assess the optimum response. These again few of the drugs, symptom related treatment, diarrhea, we can use loperamide, cholestyramine, constipation, we have studied abdominal pain, smooth muscle relaxants like hyoscine or dicyclomine, tricyclic antidepressant, gas and bloating, SSRIs, low FODMAP diet, probiotics and rifaximin. These are the doses. And what is the disease course in the IBS? This is the last point I want to emphasize. What is the natural history? How does the disease behave in the long run? In a systematic review that included clinic-based IBS patients which were followed up to 6 years. So this is generally the outcomes. 2 to 5% of patients diagnosed with an alternative diagnosis, they develop some other disease. Up to 5% of the patients were labeled as IBS, and in follow-up they develop some other GI disease. Symptoms remain unchanged in up to 50% of the patient. The disease went into remission, and when it came back, the disease severity was nearly the same. Symptoms progressed in up to 18% of the patient. In 18% of the patient, the relapse, after relapse, the symptoms kept on progressing, and symptoms improved in up to 38% patient. So that has to be kept in mind that 5% of the patients may have some other diagnosis as well, and whenever they are being followed up, any emergence of any new symptoms or any emergence of any new complaint has to be taken seriously. And what another point is, they may experience any change in the IBS subtype, with the most frequent change being constipation predominant or diarrhea predominant to mixed subtype of IBS. So this is also a particular part of the IBS. That is all. Thank you.
We can take one or two questions from the audience.
But do not have alarm symptoms. There may be some people who qualify the Rome 4 criteria, but yet they don't have alarm symptoms, and they turn out to have organic disease. Is there a subset of patients like that?
Yes. There is subset of patients who don't have alarm symptoms. They may have organic disease underlying them, but again, the alarm symptoms along with the laboratory testing reduces that subset to a bare minimum.
So therefore, you would believe
You have to do
calprotectin and
some test. You can't just go by
what
the.
is your own threshold of doing a colonoscopy?
My own threshold of doing a colonoscopy would be initially I would go through all the basic tests and give them a trial. If they are not responding, I'll go for a colonoscopy.
Not upfront.
Not up.
Not
Not up.
And what would be your message to the people practicing to a general practitioner or internist? What would be your recommendation? When should they refer a case to a gastroenterologist?
So reference in IBS is they are classified. There are again guidelines. When is the patient of IBS is to be referred to a specialist? Mild, moderate, or severe disease. The mild and moderate diseases can be managed by a physician, general physicians, or general practitioners. When the symptoms are not responding to the routine medications, or when they are requiring lab parameters are abnormal or organic disease is suspected, then they have to be referred to a gastroenterologist.
Yeah. Thank you, sir, for the wonderful presentation. So one question, in case of mixed IBS, so what is the preferred treatment and the diet modifications?
So what I do, I'll tell you what I do. There are no clear-cut guidelines as such, but mixed is a difficult to treat. What we do is we give them a plain isabgol. Isabgol, like I said, they have global symptom relief. They don't usually cause the diarrhea. Remember, plain isabgol, not mixed with egg or lactic combination that is coming. Prima Diet, Abbott, or many companies, that is plain isabgol. So that maintains a stool consistency to the normal limit. Again, some gut modulating agents like maybe some ramosetron or antiphosphotic and anxiolytic along with the
Thank you, sir. Any questions from the audience?
Probiotics have been shown to be, again, they have conflicting data. They have shown to be beneficial in predominantly diarrhea predominant IBS. So whenever a patient of diarrhea predominant IBS is there, rifaximin along with probiotic is the preferred or initial treatment that should be given. 14 days is what we follow.
If there are no questions. questions? Thank you, Dr. Rahul. Please come over here. May I now request our President, Dr. Raju Variani, sir, to come onto the stage, and Dr. Joshi, sir, President of GPA, to come onto the dais. I request all the chairpersons to join for the felicitation as well. I request Dr. Raju Variani, sir, to felicitate the chairpersons, please. May I now request Dr. Asmeet Vaidya to chair the next session. Dr. Asmeet actually needs no introduction. He is a physician from Chandralok Hospital. He has helped IMA a lot, especially during COVID times. Dr. Vagre, gastroenterologist from KM Hospital. May I request you to come onto the dais to chair the session. And Dr. Vinit Shah, sir, gastroenterologist from Ruby Hall Clinic. Please come onto the dais. Our next speaker, may I invite Dr. Pawan Hansnare, sir, onto the dais, please. He is a consultant hepatologist, gastroenterologist, and liver transplant physician at Jupiter Hospital, Baner, Pune. He is a member of Indian Society of Gastroenterology, Indian National Association for the Study of the Liver, Liver Transplant Society of India, and International Liver Transplant Society. He has experience of more than 8 years and many publications in national and international journals. Here you.
Good morning, all of you. Thank you for taking this on the dais. And with the permission, I would like to start my today's topic. The topic allotted to me is transplant. Indications, basically who are the people who we actually transplant them and when do we transplant them. So let's start with the case. I hope the slides are visible. Okay, so 39-year-old gentleman, this is a present case actually which is there in the hospital. He came with us, this is the first presentation, came with leg swelling since 2 months, abdominal distension since last 15 days, and yellow discoloration of eyes since 15 days. There is history of travel to the coastal areas in the recent past, and there is no history of diabetes or hypertension. There is no history of any complement and alternative medications. He gives history of consumption of alcohol. He has a binge drinking habit since last 10 years. Sedentary lifestyle profile, basically. His BMI is 34, and on examination he has anasarca, there's icterus, There is good amount of volume overload all over. He is tachypneic. On examination, there is a large liver palpable only in the epigastrium, nowhere else. And cardiovascular and respiratory examinations were fairly fine. There were few basal crackles, but there is no obvious effusion or consolidation on at least examination. The blood test, if you see the labs, HB is 12.3, WBC on 4,000, platelet 42,000, INR 2.2. Electrolyte sodium is low, 129. Creatinine is normal. Bilirubin total is 10.6. Direct is 6.4. Albumin is 1.6. Total protein is 7.3. SGOT 202. SGPT is 66. GGT is 200. HbA1c anti-HCV negative. Procalcitonin normal. Urine normal. No proteinuria. Pro-BNP is 453. Is normal. So this is a garden variety of decompensated cirrhosis cases we actually see in our all day-to-day practice. All of us are seeing the same cases multiple times. This is an ultrasound which has been done in our hospital, showing ultrasound liver is coarse, has a coarse ecos and has an irregular surface. Portal vein is around 13 millimeters, spleen is around 14 centimeter. The GB cal and mild free fluid in the abdomen. Echo is showing normal, mild PAH, and chest X-ray is showing prominent bronchovascular markings. So coming to the final diagnosis of the case, he is a case of portal hypertension, which is decompensated, has a decompensated cirrhosis. First presentation, volume overload, anasarca, hyponatremia, jaundice, and the etiology possibly is alcoholic steatohepatitis plus minus NASH, and child C, male 29. So this is the final diagnosis for this case. So we know that liver cirrhosis is an end-stage liver disease. There is no turning back from cirrhosis, and it doesn't become normal. The common etiologies what we face in our day-to-day practice are these. Is alcohol is most of the 60% of the cases is alcohol-related liver disease. Now we do not call them as alcoholics. The new terminology is alcohol-related liver disease. That is the one. Hepatitis B and C amount to around maybe around 10-15% of the cases. NASH and NAFLD is coming up very largely since we have a epicenter of obesity and diabetes in all over the world. That is the reason we are finding these cases quite often. Autoimmune cases are common post-COVID. We have seen a lot of cases of autoimmune liver diseases, either because of the use of multiple complementary medications or just maybe the end result of the COVID, we do not know. But autoimmune liver diseases are, a lot of autoimmune liver diseases we are seeing in last few years. Wilson's disease, not to be neglected, it's quite common and needs to have a catchy eye to find these cases. So coming to standard, we know that alcohol, it's too early for us to, I think, talk alcohol, but it's the commonest disease which can cause a liver disease. The standard drink what we see in alcoholic is alcohol is around 350 ml of beer, 150 ml of wine, or 45 ml of any hard liquor is called as one standard drink. So when a person comes to us, a person who is consuming alcohol, we generally don't write how many quarters, how many beers they consume. We write how many units they consume or amount of alcohol is consumed. As per that, we calculate what is the risk of liver cirrhosis. Coming to short pathophysiology, we know that cirrhosis is a permanent problem. It's a permanent disease. It's not, we can't cure liver cirrhosis. So what is the pathophysiology behind it? There is a chronic inflammation in the liver because of alcohol, hepatitis, or NASH, fatty liver disease, which causes continuous inflammation in the liver, causing hepatocyte death, and which leads to formation of fibrosis, which leads to the development of fibrosis in the liver. Ultimately, because of this chronic inflammation, there is an increase in the vascular, there are vasoconstrictor mediators which are released in the liver, which causes vasoconstriction, and all these factors amount to portal hypertension. So what is cirrhosis? Is loss of normal architecture and formation of nodules is called as liver cirrhosis. Portal hypertension is a after fibrosis, the portal hypertension develops, and whatever side effects or problems we see in a clinical day-to-day practice is a problem due to portal hypertension. So coming to the stages of the liver disease, if you see here, this is a normal healthy liver. The first stage starts with inflammation. Inflammation leads to fibrosis. Fibrosis leads to cirrhosis, and ultimately it's the end-stage liver disease which causes decompensation or liver cancers. So we divide clinically. We have seen just right now we have seen a pathophysiology. What we now are seeing is a clinical differentiation. we have to divide liver cirrhosis into two stages: compensated liver cirrhosis or decompensated liver cirrhosis. These are the two important factors for us in a day-to-day practice. So when a patient comes to you walking, you just have to see whether this cirrhosis is compensated or it is decompensated. These are the two important factors for a management part. What is compensated cirrhosis? That patient has a cirrhosis but doesn't have a clinically significant portal hypertension, doesn't have a complications of liver cirrhosis. And in decompensation stage, patient develops ascites, patient develops hepatic encephalopathy, varices which are there in a compensated cirrhosis can bleed, cause variceal bleed. These are all decompensations, and ultimately further decompensation will in the form of refractory ascites requiring repeated ascitic taps, requiring kidney problems, that is hepatorenal problems, multiple hepatic encephalopathy, and ultimately the patient, it leads to the death of the patient. Where do we intervene? So if we have to intervene, I would intervene at the compensated stage, prevent a person going into decompensation stage. If the person has come to you in a decompensated stage, try to manage decompensation so that we can prevent further complications. So this is how we should intervene a patient with a liver cirrhosis. So we have just spoken about all these complications about decompensated stage. So how to prognosticate a person coming to you with a liver cirrhosis? The important classification is we have been learning this from our medicine times. So there are two important things what we see. One is a CTP score and another is a MELD score. That is Child-Turcotte-Pope score and MELD score. CTP score has a 5 parameters: encephalopathy, ascites, bilirubin, albumin, and prothrombin time. These are simple apps. You can we all have smart apps, smartphones. There are apps installed for this, and you will just fill in the values. You will get a score. So child cirrhosis is divided as per the CTP score into A, B, and C stage. So child B or child C is called as decompensated. Child A is called as compensated cirrhosis. Coming to a MELD score, which is commonly used nowadays, MELD is a model for end-stage liver disease. It involves 3 parameters: creatinine, bilirubin, and INR. This is a logarithmic score. Once you put in a values in the app, you will get all the outputs, and we can diagnose these patients as what is a MELD score. The MELD score upper limit is around 40. We cannot calculate beyond that. And generally, why this MELD score is important, you can see here. If you see, this a study is showing that you concentrate on the value of 15. If the MELD score is less than 15, a survival of a decompensated cirrhosis patient with or without transplant is almost the same. So sometimes there is no benefit of putting these patients too early for a transplant. So the take-home message is that not all cirrhotic patients require a transplant. We can manage them well with medical therapy, and when a score is beyond 15 or there are a development of complications, then these patients, they need a transplant. So what are the common indications we face for a liver transplant? One is sudden acute liver failure. Acute liver failure is a sudden failure which develops within few days or weeks. The reasons commonly found is viral hepatitis and drug-induced liver injury. And third common etiology what we face is autoimmune or drug-induced related autoimmunity and liver failure. These are common indications. Other toxins like retol, Ungermanase Aushad, these are the another rare but yes commonly seen problems in this part of the world. So when the liver suddenly fails, these are the patients who generally do not survive with continued medical therapy. Most of the times they require a liver transplant, and they should be transferred to a nearby liver care unit where we can prognosticate them and see whether the patient requires a transplant or can recover from a medical therapy alone. Next is complications of end-stage liver disease, development of ascites, SBP, spontaneous bacterial peritonitis, refractory ascites, hepatorenal problems, encephalopathy, hepatic hydrothorax, that is development of right-sided pleural effusions, hepatopulmonary problems, hepatocellular carcinomas are the common indications for the liver transplant. So whenever the patient comes to you in your OPD or in hospital, we should calculate child score and MELD score so that we can prognosticate these patients and tell them that you have to start working for a transplant, and next few weeks or days you might require it. Coming to few common problems, yes, we know that ascites is the most common decompensation in a patient with a liver cirrhosis. The incidence is around 5-10% per year, and presence of ascites reduces survival from 80% to 30% directly after the development. 20% of these patients present with ascites, they die within first year of life. So this is the most important parameter. Complications of ascites, what we see commonly are, first is SBP, that is spontaneous bacterial peritonitis. That means development of infection in ascitic fluid. How do we diagnose it? We tap ascitic fluid, we send it for a routine test. If neutrophil count is more than 250 cells in ascitic fluid, that is called as SBP. Development of first SBP episode itself is an indication for the liver transplant because survival is less than 1 year after the starting of first episode of SBP. That is one. Secondarily, refractory ascites. What is refractory ascites? A patient requiring multiple taps and not getting controlled by medications, and after a salt-restricted diet is called as refractory ascites in a simple language. So these are the patients who require a repeated taps and not getting controlled, or there are side effects of the diuretics which are developing and diuretic doses cannot be escalated. These are the patients who will require a liver transplant. Hepatorenal syndrome, and ultimately whenever this problem comes, yes, we have to counsel them for a transplant. Coming to hepatorenal syndrome, this is the second most common complication we face in liver cirrhosis. Prevalence is around 27 to 53%. AKI, that is acute kidney injury, entails a poor prognosis in patient with chronic liver disease and 30 days mortality. Only 1 month mortality is around 30% to 44%. So that is, so development of acute kidney injury in a patient with decompensated cirrhosis again is an indication where we need to counsel them for early liver transplant. Hepatic encephalopathy. There are two types of hepatic encephalopathy commonly faced: overt and overt hepatic encephalopathy. Overt hepatic encephalopathy means development of obvious disorientation, there's development of flaps, patient is lethargic, or patient goes into coma. We classify this hepatic encephalopathy into 4 grades by West-Haven classification. Any episode of hepatic encephalopathy, again, the survival is less, so 1 year survival drops down drastically. So these are the patients who will have to counsel them again for a transplant. Whenever a patient comes to with hepatic encephalopathy, we have to evaluate them for an infection. So we need to find why this patient has gone into encephalopathy is important. Whether there is an infection, whether the patient has developed a bleed, whether there is a dehydration, or patient has taken any psychoactive medication, any sedatives they have taken. These are the patients who will land up in a hepatic encephalopathy. So coming to liver tumors, we knew that any tumor in the liver, which can be a primary or secondary. Primary tumors in the liver, called as hepatocellular carcinoma, is the commonest tumor what we see in patients with liver cirrhosis. Is a classical indication for the liver transplant. When a patient comes to you with a liver tumor, what we do is that we evaluate a patient, we do a CT scan or MRI to see the size of the tumor. We see whether there is a metastasis of the tumor outside the liver, and we classify the stage of the tumor. If the stage is within the Milan or within the UCSF criteria, there are different criteria what we use. If the tumor fits into those criteria and has not gone outside the liver, these are the patients can be cured with a liver transplant. The recurrence rate of a tumor after liver transplant is less than 5% if the tumor fits into criteria. Any tumor outside the liver or any tumor portal vein thrombosis is absolute contraindication. We do not go for a transplant that time. We have to give a chemotherapy or palliate them. So how do we, when a patient comes to us, so once we decide that this patient needs a transplant, what we do, we do a thorough pre-transplant evaluation, in which there are multiple tests what we do. So hepatology evaluation involves the severity and etiology of the liver disease. We calculate multiple scores as we have discussed. We see what all the complications have been there in the recent past. In laboratory tests, we do routine lab tests as our day one labs. Then we do multiple metabolic tests also. Thorough checkup is done for the viral markers, autoimmune markers, as well as prothrombotic markers. We do check for all the patients who are coming for a transplant. A detailed evaluation by imaging by a CT, MRI is done. A cardiopulmonary evaluation is really important for us. We need to find out, is there a complication of liver cirrhosis which has developed in a patient with in a cardiopulmonary way. So we do spirometries, ABGs, echocardiography, dopamine stress echo, CT coronary angio, sometimes even conventional coronary angio to rule out coronary artery disease before going for a surgery. Psychological evaluation is paramount important, because unless until we have a clearance from the psychologist or they give a clearance, we cannot proceed for the transplant, especially patients who have an alcohol use disorder. infectious etiology like CMV, EBV, HSV, VDRL, TPHA, all and TB screening, all these tests are done before a transplant. Then each specialty, including anesthesia, they see the patient and clear them for a transplant. So coming to the types of a transplant, what are the types of a transplant? There are two types. One is a cadaveric transplant, where whole of the liver is changed and a new liver is given from a cadaver, that is DDLT. Organs are generally donated after the brainstem death and when the family gives a consent. This is called as organ donation, and after organ donation, when we receive an organ, we give it to a suitable donors, suitable recipients. Next is a living donor transplant, where there is a part of a liver. So if you see here, if this is a whole liver, right lobe is mostly taken for the adults and left lobe is taken for the pediatrics. So the whole of the liver from a recipient is taken out, and this part of a right lobe of the liver is transplanted into the recipient. This is called as living donor transplant. So these are the two different transplants. Who is a donor? A donor is only a family member can donate in a live donor setting. What are the differences between the living and cadaveric donors? So the basic difference, what I will tell you, is a waiting period. We know that organ donation is picking up nicely now, but there is a lot of patients are waiting for the transplant, and the organs are really scarce. So what we need is more and more donation and more awareness of general public, so that the donations will increase and we will have more patients getting benefited. So cadaver, the problem is the waiting period. So on an average waiting period for a cadaver is 6 months to 1 year to receive an organ. In living donor setting, there is no waiting period. Once we have a donor in the family, once you work up, if the donor is fit enough, then we can go ahead and do the transplant. That is a basic difference between these two. Donor selection, as I said, only a family member can be a donor. Age group, what we select is between 18 years to 50 years. Blood group compatibility, and BMI should be less than 30 years. We do all viral screening for all the donors. We do imaging in its form of a CT to see the volumes, so that a good amount of volume is left behind with the donor, and a good amount of liver is also given to the patient, so that there should not be a small for size to the patient. So once we do a transplant, these are the patients. So donor usually gets discharged at day 5 of a transplant. Patient gets discharged at day 10 of a transplant, and they keep under follow-up. What we see for a follow-up is that every weekly we do the test for the recipients. So how the new liver works is we see every weekly in a blood test. There is no other way we can monitor how the new liver is working. So every weekly we do the blood test. We give them immunosuppression, we monitor immunosuppression levels, and immunosuppression is monitored every weekly in a blood test. Side effect of the immunosuppression is also monitored well. And what the commonest immunosuppression what is used in a liver transplant setting is tacrolimus, mycophenolate, and steroid. Steroid goes off within 2 months, mycophenolate goes off after 6 months to 1 year, and tacrolimus is given lifelong. So this is a general immunosuppression for a patient. Donors, generally nothing is required, because naturally whatever amount part of a liver is taken from the donor is around 50 to 60% of the liver. The whole of the liver, whatever has been taken back, grows back to its normal size within 6 weeks, 4 to 6 weeks. And the maximum growth happens in first 2 weeks, remaining growth happens after 4 weeks of a transplant. So donor can go back to their usual working schedule by around 1.5 months to 2 months. So this is a general idea about the post-transplant scenario in donors and recipients. So coming to a small last slide, this is, I think we have done around more than 250 transplants. 86% of them are living donor, 14% are cadaveric, and the total success rate of last year is around 93.6 to 93.5%. This is our beautiful team, without which I cannot be here. And thank you for your patient listening. I am open for questions.
So very excellent talk, Pawan. You made the basic concepts about liver transplant very clear. As this forum predominantly consists of physicians and primary care physicians, I think so a patient trusts a primary care physician more than anybody else. So there were two important questions. One, which a question commonly patients would ask to a primary care physician when they would suggest a transplant to the patient and refer to you, is what is the realistic survival after transplant, considering all the factors. So your advice or your thoughts about the realistic survival which a primary care physician should tell to the patient. Second, you told very clearly that alcohol is the most common reason for liver disease in our part of the country. So many times the alcohol stopping by the patient before he reports with liver disease is not adequate. So again, questions by relatives and the primary care physician is, in such scenarios, what would be your advice with regards to liver transplant?
Okay, so thanks Vinit for these questions. So coming to the first, I'll start with alcohol first. I think that is more interesting. So whenever a patient who has come to us with alcohol-related liver disease, abstinence, which what we follow is around 6 months by rule. But sometimes, only exception to this is severe alcoholic hepatitis, when the severity of the liver disease is so bad that the patient cannot survive. In selected few patients with severe alcoholic hepatitis, even without abstinence also sometimes we might have to go ahead, but that is after counseling to the family and after only psychological evaluation. Not all the patients who will directly go for a transplant, but on an average, this 6 months rule has come down to around 3 months now. So 3 to 6 months abstinence with a good psychological evaluation. This is a complete team effort. A single hepatologist or a liver transplant surgeon cannot do this. We need a good psychological association and the team. These people needs to be evaluated before and 100% needs post-transplant counseling, because recidivism means starting of alcohol after transplant is seen in around 5 to 10% of cases. So counseling post-transplant is also equally important, how much ever it is pre-transplant. That is one. And first question was, I think you were correct. So survival is another most important thing. Even whatever I've told you, 93.5% survival is around 1 year survival. I'm telling you 6 months to 1 year survival. What I'm telling you, the most important survival depends upon what is a patient's condition when he is going for a transplant. This is the most important thing. If the patient is well maintained means it's a robust patient without sarcopenia, then these are the patients who survive really long. A patient who is sick to start with, to go inside a transplant, the outcomes are not really great. So acute and chronic liver failure patients who are really sick, ऐसा नहीं है कि we don't transplant patients with a ventilator or dialysis, we do transplant them. But a patient who is walking on his own feet, he has a good muscle strength, the outcomes are robust than a patient who is on a ventilator and dialysis going for a transplant. That is a basic answer. There is no clear-cut answer to your question, but this is how it is. So timely patient coming to the transplant is the most important thing that I would advise, rather than anything else. Margaret, sir?
A common enigma and where general physicians and primary care physicians can contribute is on organ donation.
Yes, sir.
What would be your advice to these physicians? Because many times the patient's relatives in the ICU and they have been told that the patient is brain dead. But there are a lot of misunderstandings. Some people will say no, they are unnecessarily declaring and whatnot. Lot of questions to come. So what would be your suggestion to these primary care physicians? How they should direct these relatives if they approach them, whether organ donation can be considered on their patient who is otherwise not going to survive?
So it's a complex problem. I think a lot of social issues are also involved. So once we diagnose patient as a brainstem death, once an intensivist tells you the patient is a brainstem death, I think there should be a team along with a person who actually counsels them. It's a sensitive area to counsel a patient with a brainstem death, to tell them near of loved one to donate their organs because he's not going to survive anymore. But it should be taken gradually, but as we are really in need of good organs, because the patients are dying, the mortality on a waiting list is very high. So definitely, if you see a patient who has a brainstem death and you have a good medical social support, or we can provide you like any transplant center around you, there are medical social workers who are working with them. They can come to your center and counsel along with you to the families, which can be used, which you cannot counsel sometimes. So these are the few things what you should involve. If there is a person, please contact a medical social worker to a nearby transplant center or your intensivist to talk to them and help them for an organ donation. That is what I would advise.
The donor should stop alcohol before
So donor taking alcohol we do not take. That is one. So if a patient donor is consuming alcohol on regular basis, they are actually excluded as a donation. But occasional social drinking, sometimes yes, we evaluate as a detailed history, and we sometimes do a donor biopsy also to actually see what is there in the liver, and then only take the donors. The donor criteria are actually, the tests for the donor are more than the recipient, if you ask me. So the amount of the tests we do to the donors are more. So yes, because donor is really a precious person who is going for a surgery for a greater good. So definitely needs more evaluation and care.
Yes.
Question from the audience?
In case of a non-alcoholic liver disease,
Yes, sir.
particularly monitoring by ALT levels and fibrous scan. So, what would be the prognosis? Is it a
So, correctly pointed out question, sir. So, as we have I just told you that fatty livers are very common, and we are in after alcoholic liver disease. I think fatty liver and NASH is going to be the next disease which is going to have a decompensation in next few years. 100%. It's going to cross viral hepatitis also. Any fatty liver coming to you, first what we do is just do a basic liver function test. If liver function tests are normal, the next step should be a fibroscan or elastography. If elastography is normal, what we just need this patient to have a basic management, lifestyle management, what is required. If these patients are diabetic, diabetes management is paramount important. Weight loss is another thing. If the patient has only, this is called as isolated fatty liver without NASH. Isolated fatty liver, 5% of body weight loss is what we suggest to them, and these patients recover from them. We do not actually go for ultrasound guided recovery of the fatty liver. This will not happen in these patients because it's very subjective. So what nowadays we do fibroscan. There are now CAP score. What we see, the amount of fat in the liver is also being calculated on the newer machines. So this is called as isolated fatty liver management. The pharmacotherapy actually comes into picture when there is a NASH, that is non-alcoholic steatohepatitis, next step of a fatty liver. When these are the patients who will land up in liver fibrosis, and these are the patients who will land up in liver cirrhosis. Even cancers are really common in patients with NASH without development of cirrhosis. Nowadays we are seeing those, and middle-aged, 40s, 50s, directly coming up with liver tumors because of the background NASH. So liver function test, fibroscan, and maybe you can actually involve one of the liver specialists around you to help you. So these are the few things what I would do. And fibroscan, if you ask me, fibroscan should come into a yearly health check rather than once in a while test. Both are synonyms, sir. So whichever machine is available to you. All the studies which have been done internationally are by fibroscan machines. Ultrasound elastography, the studies are not really more. Ultrasound again is a subjective thing. Even fibroscan is a subjective thing. But the machine gives a value, and you have to, what we do is around 10 readings or maybe 15 readings of those scans. There should not be much variability. If you see a scan, you directly see a report. What we see is variability, interquartile variation, or a variability between these two things. All 10 markings. If there is not much variability in 10 readings of that fibroscan, then it is a fairly well done fibroscan. Nowadays, what we also use is MRI elastography. This is the best, almost touching liver biopsy. So if you have a doubt, or there are two different readings coming from one machine and another machine, MRI elastography will not lie.
Any more questions? Okay, I'll just briefly ask you one question just
Yes.
to evoke interest.
Sure.
Metabolic liver disease, you find pediatric patients transplanted. By the time they come to adulthood, they are not compliant, or there is disease recurrence in some cases. What is the experience of retransplant in India? Whether this is entertained at all, like in the West for alcoholic liver disease, they have proven that almost 50% patients who are transplanted will go back to the bottle. So what is the incidence of retransplant in Indian scenario? Any experience?
So I do not know I'm not able to comment you on the Indian scenario, but right now I have a patient who is admitted presently with me, transplanted 3 years back, had a recidivism, decompensation, stopped, and now developed with graft failure or liver failure. So I think it is less than 1%. I'm not really sure about the percentage. I cannot comment. But yes, retransplants are quite common. The problem, what you highlighted, more important, is a metabolic syndrome post liver transplant, which are very common. So as a general care physician, what we generally do is there's a handover clinic, or we hand over patients to our primary physicians from where the patient is coming to us. Because patient is in Pune, I can handle it. But patient outside Pune, with a major chunk of a patient coming from outside districts, so we generally connect to a primary care physician, who is catering them to that center in that city. We tell them regular health checks, basically lipid profiles, diabetic workup, and a fibroscan every yearly to patients who undergo liver transplant. A major problem what we see post-transplant is a rapid weight gain of these patients because the disease is gone, they eat voraciously, and you can see weight gain of around 10 to 15 kgs within 6 months. So this is what we need to actually counsel them.
No more questions, then we will move on to the next session. Thank you very much, Dr. Pawan.
Yeah, thank you, Dr. Snaya. May I request our President, Dr. Raju Variani, to come on to the dais, and Dr. Sahil Rasne sir to come on to the dais to felicitate Dr. Ansna. Dr. Sunilingai sir, please join for the felicitation. May I request all the chairpersons to join? Thank you, everyone. May I take this opportunity to invite today's MMC observer, Dr. Pathare sir, onto the dais, please. And I request Dr. Sanjay Patil to join for the felicitation. I also take this opportunity to welcome some dignitaries. Dr. Vinay Thorat sir is here. Welcome sir to the IMA. Dr. Amol Bapia is here. Welcome. My dear friend and batchmate, the great Dr. Sanjay Lalwani is here, Principal of Bharati Vidyapith. Welcome Dr. Sanjay. We are not now going to have a small inaugural function over here. So I would request the staff, please help me to get the summary. आपण एक छोटंसं दीप प्रज्वलन करणार आहोत. May I request all the dignitaries, Dadasaheb Maindad, Dr. Dadasaheb Maindad, please come on to the dais. Dr. Sanjay Lalwani, please come on to the dais. Dr. Vinay Thorat sir, Dr. Amol Bapia, Dr. Akhil Nagpal sir, please come on to the dais. Dr. Shiva Iyer sir, please come. Dr. Sanjay Patil sir. Dr. Padma Iyer madam, please come on to the dais. Raju sir, Variani sir, please come.
आता येस दादासाहेब मांडा. त्या नंबर
I request Dr. Thorat sir to say a few words.
Good morning, everyone. I won't take much of your time, but I think gastroenterology has come a long way. I came in 1988. That's almost now 35 years, and a lot of young gastroenterologists have joined. And we have been teaching also, and we have been learning also. And this is a good experience to learn from the young people, because if you are a teacher and if you stop being a student, then you stop being a teacher. So I thank everyone for calling me here, and best wishes to everyone in the team.
ये तुझ कर होता ना सार्थक. तू हेडफोन देतो का नाही? कॅमेरा हलवला ना. तू मला काहीच कशाला बोलतो?
एक सूचना आहे 6752. ही कार जर कोणाची व्हेकल तर त्यांनी प्लीज काढा. प्लीज रिमूव्ह द कार व्हेकल नंबर 6752. So let's now move to the academic session. So to chair the next session, may I request Dr. Shiva Iyer, Professor and HOD of Critical Care Medicine, Bharati Vidyapith. Dr. Padma Iyer, madam. Dr. Padma Iyer, madam, is the past past president of IMA Pune, she is a consultant surgeon, and Dr. Nachiket Dupade sir, gastroenterologist from Pune Hospital. And for the next talk, may I request Dr. Dadasaheb Maindad to come on to the dais, please. Dr. Maindad needs no introduction. He has done his MD Medicine from Government Medical College, Miraz, DNB from Manipal Medical College. He is the Associate Professor of Medical Gastroenterology. Has more than 10 years of experience in gastroenterology, and he is expert in ERCP. His areas of interest is mainly hepatology. He has many national and international publications, and he is a member of INASL, that is the Indian National Association for the Study of the Liver, and Indian Society of Gastroenterology. Recently, he received a Maharashtra Leadership Award in Health Sector. Congratulations, Dr. Maindad.
Thank you, madam. Good morning, all delegates. Today's my talk is on decompensated liver disease, which is very common we are seeing in day-by-day practice, and I am making it more simplified so that you can manage these patients very easily at your practice. So I am going to cover what is meant by decompensated liver, how it develops, what are the complications, and how to manage this decompensated liver disease. So decompensated liver disease is acute deterioration in the liver function due to any cause. So it is called as a decompensated liver disease. So to make this definition more concrete and uniform, it is simplified with characteristics like jaundice, ascites, hepatic encephalopathy, hepatorenal syndrome, or GI bleed, variceal hemorrhage. If any character is developed in a patient of chronic liver disease, then it is called as a decompensated liver disease. Why this decompensated liver disease is important? Because the survival rate will reduce drastically from 12 years to 2 years. And every year 5 to 7% of the patients from compensated stage, they will progress to the decompensated state. So as I told, when liver is in a compensated cirrhotic state, there should be some insulting factor which will cause the acute decompensation. What are these acute decompensating and precipitating factors are? Like infections, GI bleed, alcohol intake, drug-induced liver injury, and in more than 50% of cases, we will not get the exact etiological factor for this precipitation. Once there is a decompensation, it will get complicated by one or other complications, and patient will develop different type of complications. Patient repeated hospitalization, hospital visits will increase, and these are bleeding, hepatorenal syndrome, acute kidney injury, then cirrhotic cardiomyopathy, bacterial infection, hepatocellular carcinoma, and so on. So that due to these complications and decompensation of the liver function, patient will develop early death, and the survival will decrease from 12 years to 2 years. So how this decompensation develops? There is an old pathophysiology that there is a peripheral vasodilatation, so that the functional blood volume will get pulled to the periphery, and patient will develop the effective hypovolemia. In these patients also develop cirrhotic cardiomyopathy due to the peripheral vasodilation. There is a continuous decreased peripheral resistance and increased heart rate, which will lead to the cirrhotic cardiomyopathy. Then there will be the pulmonary circulatory changes due to the ventilation perfusion mismatch, as well as due to the increased pulmonary artery pressure. There will be the dysbiosis due to the change in the intestinal permeability and motility, bacterial translocation. Then this is a chronic inflammatory disorder, so that in these patients there is a systemic inflammation. It is not just related to the liver, so that this is again continuous inflammation all over the body, and the oxidative stress is high. In these patients, there is a decreased immunity, so recurrent infections will be there. So combination of all these pathogenic factors which lead to the decompensated liver disease. So what is our aim in treating the patients with decompensated liver disease is to suppress the inflammation. Whatever inflammation is going on in the liver, we have to suppress this inflammation so that further damage will not happen. Then whatever damage is there, that is a fibrosis, try to reduce this fibrosis, then decrease the portal pressure and improve the portal and arterial circulation in the liver, and maintain the cell count in the liver. So whatever cells already dead, suppose patient is having decompensated liver disease, most of the time the cell count will be less than 30%. In that case, our prime is to preserve that cell count so that the decompensation process will suppress and the lifespan will prolong. So basically, decompensated liver disease management will divide it into the three, that is treatment of the etiology, treatment of the pathogenesis, what we saw in the last slide, and treatment of the complication. In this treatment, first we have to evaluate the patient with baseline examination, whether patient is having ascites, whether patient is having other complications. Then do the etiological workup, because our first aim to treat the etiology like viral markers, autoimmune hepatitis panel, rule out the infection, hepatocellular carcinoma, and Wilson's disease, hemochromatosis. Like this, we have to rule out the etiological factors. Rule out the complications, because our third arm is to treat the complications like infection, SBP, GI bleed. So it is very easy. First, if you will identify the etiology, treat the etiology, that ask patient to stop alcohol consumption, treat hepatitis B and C, treat autoimmune hepatitis, portal vein thrombosis, infection. If patient is taking some drugs which is causing drug-induced liver injury and which is responsible for the decompensated liver disease, we have to ask patient to stop the drug intake and treat other etiologies like hemochromatosis and Wilson's disease. The management of the pathogenic events, once we identify the etiology and we will treat the etiology, then our next aim is to identify the pathological event. What is the acute problem which is leading to the decompensation is infection, whether there is a peripheral vasodilatation, then cardiomyopathy, dysbiosis or translocation. For treating these etiological parameters, for the infections, we have to send patient different cultures like urine culture, blood culture, ascitic fluid cultures, and according to that we have to start the antibiotic. For the peripheral vasodilatation, we have to use the vasopressor so that the peripheral vasodilatation will decrease and patients further cardiomyopathy and circulatory dysfunction will get improved. For the portal vein thrombosis, we have to use the low molecular weight heparin. And in patient with dysbiosis to prevent the dysbiosis and translocation, we have to use the probiotic. Fecal microbiota transplant is the other option for the intestinal dysbiosis and translocation, but it is not very well studied still to prevent the further decompensation. Management of the specific complication. Usually patient will come to us in the general OPDs with these complications. The etiological factors we treated, we will treat the precipitating events, and then we have to identify the complications like infection, ascites, hepatic hydrothorax, hyponatremia, hepatic encephalopathy, hepatorenal syndrome and GI bleed, and we have to treat these complications one by one. Infection, 48% of the infections are community acquired in the cirrhotic patients, and around 26% infections are healthcare associated, because this patient will visit repeatedly to the hospital and get repeatedly admitted in the hospital, so that this patient will develop the healthcare associated infection which will get diagnosed within 48 hours of the admission. 26%, remaining 26% of the patient will develop hospital acquired infection which will get diagnosed after 48 hours. So this type of infection will get detected in these patients. positive bacterial culture is not very good marker to identify the infection because it is positive only in 60% of the patients. So 40% of the patients culture will be negative. And in this patient, most common infection will be SBP, followed by the urinary tract infection and pneumonia. What is the major concern? Due to the random use of the antibiotic, nowadays multi-drug resistance bacteria is increasing. And if you see at the bottom, there is a red line, especially in India, where 70% of infection in patient with cirrhosis are due to this MDR organism. So again, it is very difficult to treat this infection in these immunocompromised patients because these patients are immunocompromised and weak organisms are multi-drug resistance. So they will respond less to the routine antibiotic which are recommended in the guidelines. The most common infections are spontaneous bacterial peritonitis, urinary tract infection, pneumonia, spontaneous bacteremia, soft tissue infections, then C. difficile infection, and even in 10 to 30% patients will see the fungal infections. In these patients, fever is not good clinical marker because they are immunocompromised and malnourished, so they will get the less febrile response. So when we have to suspect there is an infection, when patient is admitted in the hospital and he is having some clinical features like fever, chills, or he is developing some liver-related complications like acute kidney injury, altered sensorium, or he is having organ failure, and as I told, culture is not very good marker. We have to take support of other marker like C-reactive protein and procalcitonin. Antibiotic strategy. In all guidelines, empirical antibiotic therapy is mentioned for the different infections, but we have to choose the antibiotic depend upon the severity at the presentation, then source of the infection. Suppose patient is having healthcare associated infection or hospital acquired infection, then we have to consider the MDR organisms, and if patient is not responding or patient is having severe infection, then we have to go beyond the guideline and use the higher antibiotics. Then consider the regional bacterial resistance pattern, and according to that you have to choose the antibiotic. If we will delay the antibiotic use in this patient, mortality will increase 2 times every hourly. So that early use of the antibiotic and early suspiciousness of the infection is very important. Once we will get the culture reports, then we have to de-escalate the antibiotics so that we will preserve the antibiotic and will not help to get more and more MDRs. Albumin infusion is useful in these patients, which will increase the opsonization and improves the bacterial and improves the antibiotic effect. Then most important is prevention of the infection. One is treat the infection, but it is better to prevent the infection. Antibiotic prophylaxis is advised in all in SBP patients for the lifetime. In patients who are having gastrointestinal bleeding, in this patient the sepsis rate and SBP formation is high. And in patients with advanced cirrhosis, those are having child C with serum bilirubin more than 3 and ascitic fluid less than 1.5 milligram, we have to provide them with norfloxacin 400 milligram as a primary prophylaxis to prevent the further attacks of the spontaneous bacterial peritonitis. What is the disadvantage of the prophylactic antibiotic strategy? That it will cause the more and more antibiotic resistance. The other strategy to prevent the infection is vaccinate these patients with hepatitis A and B vaccines or herpes zoster vaccine, pneumococcal vaccine and influenza vaccines. We are not vaccinating this patient routinely, but at least vaccinate this patient with hepatitis B vaccine. Nowadays, syndromic panel, that is PCR tests are available which will diagnose the common organism which are causing the infections. This test is available and this PCR test will detect very easily the common organism which are causing the infection, and it is more sensitive than the routine cultures which is sensitive just 60%, but we are right now having few challenges like it's having costly, contamination can give the wrong result, then we will require the more expertise. So other most common complication is ascites. The ascites is the 5 to 10% of the compensated cirrhosis per year develop this ascites. Adverse effects are the patient will get the abdominal discomfort, his day-to-day lifestyle will get hampered, he will require frequent hospitalization and treatment for the ascites. Then ascites patient will develop SBP, then restrictive ventilatory dysfunction and abdominal hernias. As ascites develop, the survival rate of this patient will deteriorate very drastically. 1 year survival in decompensated patient with ascites is 60%, where without ascites it is 80% at 5 years. And if we will see DCND patient with ascites, 5-year survival is only 30%. So there is a quite disastrous decrease in the survival rate once patient will develop the ascites. Ascites is graded into 3 grades. Grade 1 ascites is diagnosed only by the ultrasound. Grade 2 ascites is diagnosed by ultrasound as well as clinically there is only symmetrical distension of the abdomen, and grade 3 is a gross ascites. So depend upon the ascites grade, we will formulate the therapy for ascites management. Once we will get the ascites patient, we have to evaluate this patient with history, physical examination, abdominal ultrasound and laboratory markers. Ascitic fluid we have to send for the analysis with total count, differential count, protein and albumin. If SAG is more than 1.1, then this ascites is secondary to the portal hypertension, and if neutrophil count is more than 250 cells per cubic millimeter, then it is called as the SBP. Whether culture is positive or negative, neutrophil count is considered as the diagnostic parameter for the diagnosis of SBP. In grade 2 ascites, usually it is treated as a OPD patients. Sodium restriction is the one of the method to treat the ascites. It causes ascites resolution in the 10% patients only. The clear advantage of the sodium restriction is not there. It will reduce the ascites formation, but only sodium restriction will not reduce the ascites. So new ascites formation will reduce, but the already whatever ascites is there, it will not get reduced only by the sodium restriction. If we will restrict the sodium very strictly, then patient will develop the hyponatremia, then food will be the unpalatable and patient oral intake will decrease, patient will develop the renal failure. Then so that the moderate sodium restriction is recommended, that is 4.6 to 6.9 gram salt is allowed to take patient per day. The other method, whatever the ascitic fluid is there, we have to mobilize that fluid with the diuretics. So we have to start with the spironolactone 100 milligram once a day, and we can increase it to 400 milligram. We have to wait till the 72 hours to see the response to the spironolactone, because it is slow acting diuretics, and if it is not acting after 3 days, means we have to increase the doses, we have to double the dose and reach up to the 400 milligram. If patient is not responding to the spironolactone or patient is developing hyperkalemia, we have to add the furosemide as a loop diuretics, which will mobilize the fluid more efficiently. That is, furosemide should start with 40 milligram and increase up to the 160 milligram. So how much diuretics we have to increase and we have to start, and which basis we have to evaluate the patient. That is, the expected weight loss is 0.5 kg every day if patient is not having edema, and if patient is having edema, expected weight loss is 1 kg per day. This much of weight loss is not there, means we have to increase the diuretics. If weight loss is more than this, chances of hepatorenal syndrome and acute kidney injury will be there. If these patients are not responding to the routine treatment, we have to go for the large volume paracentesis. During the diuretics therapy, we have to monitor blood pressure, serum creatinine, electrolyte, and look for the hepatic encephalopathy. In grade 3 ascites, patients who are having gross ascites in these patients, their routine activity will get disturbed. Patient can develop the umbilical hernia, patient will develop the hepatic hydrothorax, and patient will develop the dyspnea. So that in this patient, large volume paracentesis is recommended. Routinely FFP or platelet transfusion is not recommended, and there is number of studies which mentions that there is no chances of bleeding even if the platelet count is less than 50,000 and INR is more than 1.5. But few centers prophylactically uses FFP and platelets when INR is less than when INR increases more than 40% and platelet count decreases less than 40,000, then some center advises to use the FFP and platelet count. Large volume paracentesis should be avoided in the decompensated liver disease, and whenever we are doing the large volume paracentesis, we have to use the volume expanders. When we are doing the large volume paracentesis, when we removing the fluid less than 5 liters, the other than albumin, we can use the dextran or polyclean as the volume expanders, and their results are as equal as albumin when paracentesis is less than 5 liter. But when we are doing the large volume paracentesis more than 5 liters, we have to use the albumin as a volume expander as 8 gram per liter, and we have to continue the diuretics to prevent the further accumulation of the ascites. Drug which causes the precipitation of the ascites formations are AC inhibitor, ARBs, alpha blockers, aminoglycosides, and contrast. IV contrast, there is again controversy. It is not clearly proved that IV contrast used in CT scan causes the kidney injury in decompensated liver patients, but we have to use carefully in these patients because their renal function is already compromised. Refractory ascites is called when we are not able to mobilize the fluid in adequate quantity, when patient's weight loss is not adequate in spite of the adequate dose of the diuretics. It's called as the diuretic resistance ascites. And diuretic intractable ascites is ascites when we are not able to mobilize the adequate fluid because patient is developing complications secondary to the diuretics. So how to treat these refractory ascites? Large volume paracentesis, stop diuretics. Diuretics can be used only when there is a sodium excretion is more than 30 millimole per day. In that cases, yes, their kidney function is quite good, and in that cases only we can use the diuretics, but otherwise you have to stop the diuretics. What happens when patient is not getting the adequate output? When patient is having gross ascites, we will increase diuretics drastically. We will give the IV diet or IV diuretics, and patient will develop more and more kidney injury. Beta blockers, whether to use the beta blockers in resistance ascites or in decompensated state is controversial condition, because many newer studies says that beta blocker decreases the portal hypertension so that refractory ascites reduces, but beta blocker same times causes peripheral vasodilatations and it can increase the refractory ascites. So again there is a controversy. Those patients who are not responding to this medical therapy, other options are TIPS or midodrine and alpha pump implantation. Hepatic hydrothorax is collection of the fluid in the thoracic cavity in the patients with decompensated liver disease. We have to rule out the other causes for pleural effusions, and treatment for hepatic hydrothorax is diuretics and albumin. Those patients who are not responding to the diuretics and albumin, we have to go with the TIPS, and patients not suitable for TIPS, we can go ahead with the fluorodesis. Hyponatremia is another common complication we will see. There are two types of hyponatremia. One is hypovolemic and one is hypervolemic. Hypovolemic hyponatremia usually develops secondary to the use of diuretics, and patient decrease oral intakes. If we will use the excess diuretics, patient will develop the hypovolemic hyponatremia. In that case, replace the volume of these patients will correct the hypovolemic hyponatremia. Then hypervolemic hyponatremia develops secondary to the fluid accumulation. That free fluid accumulates in the abdominal cavity and in the peripheral edema forms, so that the dilutional hyponatremia will be there. And in that case, we have to use the diuretics, we have to use the albumin, and we have to restrict the fluid only if patient is having severe hyponatremia. but restriction of the fluid will not help much. So the restriction of fluid is not routinely recommended, only recommended when it is symptomatic hyponatremia and sodium level is less than 120 milliequivalent. Then the complication, next complication is gastrointestinal bleeding. Many times we are seeing this complication in emergencies and in our OPDs. So that first is discontinue non-selective beta blockers because these are not recommended for the acute GI bleeds. These patients So variceal hemorrhage occurs secondary to the rupture of esophageal varices. Patient in whom decompensated develop should have go for the upper GI endoscopy. Those who are not diagnosed, and if there is a diagnosis of large or moderate size varices, then we have to treat them with the esophageal variceal bandings. Those patients having small varices, those if patient is having CTP-C, then we have to treat them with the either primary prophylaxis or secondary prophylaxis. Primary prophylaxis, when we have to advise the primary prophylaxis, those patients are having small varices with child C, and those patients are having large varices with and moderate varices. Those are not bleeding. We will give the non-selective beta blockers or EVL as a primary prophylaxis. But how to choose the primary prophylaxis? It is based on the local resources, then patient preference and contraindications. Non-selective beta blockers are better than the EVL banding because non-selective beta blockers causes decreased portal hypertension, so that it will prevent the further complications. When we are using the non-selective beta blocker, we have to take care of the complications like whether patient is developing acute kidney injury, whether patient is developing sepsis, SBP or bleeding. In that case, we have to discontinue this non-selective beta blocker. For secondary prophylaxis, we have to use combination of non-selective beta blockers and endoscopic band ligation. In acute bleeding cases, first we have to resuscitate as our routine ABC formula, airway, breathing and circulation. We have to start resuscitation with the crystalloids. We have to start antibiotic, FFP and platelets we have to give, and packed cell transfusion should be given. Our target HB should be 7.7 to 8 grams. Pharmacotherapy is as good as endotherapy, and immediately we have to start pharmacotherapy. Terlipressin should be start with a 2 milligram per every 4th hourly during first 48 hours, followed by 1 milligram every 4th hourly thereafter, and we can continue it for 3 to 5 days depend upon the severity. Somatostatin and octreotides are the other options for it. Octreotide is as good as terlipressin, and we have to start with the 50 microgram per hour as an infusion after 50 microgram bolus dose. Short administration can be considered in the less severe cases. In gastrointestinal bleeding patients, we have to go with endoscopy and endoscopic band ligation or sclerotherapy. Before the endoscopy, we can use the prokinetic so that the stomach will be empty and we will get the better vision. So either we can use the erythromycin 250 milligram IV bolus. Guidelines are not recommending, but metoclopramide also is a good prokinetic which will give us a good vision. The other option for variceal bleeding is cyanoacrylate injections. It is used basically in the gastric variceal bleeding and less commonly used in the esophageal variceal bleeding. 10 to 50% of the patients will develop the rebleeding, and in this patient we have to use the rescue methods. SBP is the other complication. When there is a more than 250 cells, 250 neutrophils in the 250 neutrophils per cubic millimeter in the ascitic fluid, whether culture is positive or negative, it is called as SBP. It can be present as abdominal pain, diarrhea, paralytic ileus, fever, leukocytosis or hepatic encephalopathy. We have to treat with the empirical antibiotic because culture will take time. Start cefotaxime 4 gram per day. Amoxiclav can be used as alternative. Ciprofloxacin IV we can use, but again there is a more resistance bacteria to the fluoroquinolones, so ciprofloxacin is having less efficacy. Oral ofloxacin can be used in patients those are stable. Piperacillin, tazobactam and carbapenem are considered in a patients with in the setups with high multi-drug resistance bacteria. Once we will start the empirical antibiotic, after 3 to 4 days, once we will get the cultures, we have to de-escalate the antibiotic. Albumin will help the improvement of the SBP. Albumin is recommended for the 3 days with 1.5 gram per kg as a dose, and it is recommended in a patient those are having serum bilirubin more than 4 milligram or serum creatinine more than 1 milligram per deciliter. Secondary prophylaxis is offered in all SBP patients, and it should be for the lifetime or till their liver function will get improved. Renal impairment, old definition was if serum creatinine is more than 1.5, it is called as HRS, but newer definition is changed when there is increase in a serum creatinine by 0.3 or increase in more than 50% of the last creatinine, then it is considered as HRS. Then in treatment we have to assess the precipitating factors like infection, diuretics, use, then GI bleed, therapeutic paracentesis or nephrotoxic drugs, and we have to remove this precipitating factor. Diuretics should be discontinued. As I told, once there is a decreased urine output, we will get uneasy and we will increase more and more diuretics, but it will cause more and more kidney damage, so that we have to discontinue the diuretics. Crystalloid or albumin can be used for the volume expansion, depend upon the patient hydration status. Discontinue all nephrotoxic drugs. And volume replacement should be considered in a patients those are having diarrhea or very high dose use of the diuretics. Then blood replacement therapy we have to use if patient is having GI bleed and anemia. In drugs, we have to use the albumin 20%, 1 gram per kg body weight, up to maximum 100 gram of albumin can be used for the 2 consecutive days. If it will develop, the acute kidney injury will improve, then it indicates that there is a perirenal AKI, and these patients there will not need of further treatment. Terlipressin or vasopressin analogs are used to treat the patient those are not improving after 2 days of the albumin. Terlipressin is used with a doses of 0.5 to 1 milligram every 4 to 6 hours and increases up to 2 milligram every 4 to 6 hours till the response we will get the response. When we will say there is a response when there is a creatinine is less than 1.5. Always terlipressin should be combined with the albumin with 20 to 40 gram per day. The most common side effect of terlipressin is diarrhea, abdominal pain, circulatory overload and cardiac ischemia. Complication reported into the 45% of the patient. Discontinuation is required in the 20% of the patients. We will say complete response if creatinine is less than 1.5 and partial response if serum creatinine is more than 1.5 but decrease more than 50%. Then hepatic encephalopathy is the last complication. When it is a reversible alteration in the mental status of the cirrhotic patients, then overt hepatic encephalopathy is divided into the 3 categories, that is grade 2, grade 3 and grade 4, and covert is a minimal and grade 1 encephalopathy. In these cases, patient's mental status is almost normal. So how to treat this hepatic encephalopathy? Is most common is non-absorbable disaccharide lactulose or lactitol is used, which will cause the purgation as well as change in the intestinal pH and dysbiosis, so that ammonia formation and absorption will reduce. Lactitol is better than lactulose, and we have to use 30 to 45 ml of the lactulose every second hourly till patient will get the 2 loose stools, and subsequently we have to adjust the dose that patient should get 2 to 3 bowel movement per day. Other options for the treatment of hepatic encephalopathy, rifaximin. So if patient is not responding to the lactulose, we have to add the rifaximin as the add-on drug. We can use at a 550 milligram twice a day or 400 milligram 3 times a day. We have to use these in a combination when patient is not responding to the monotherapy. Other drugs are neomycin, probiotics, zincs, branch chain amino acids, and L-ornithine, L-aspartate. Fecal microbiota transplant is still in the trials. After treatment, we have to continue prophylaxis with either lactulose or either rifaximin. And if patient is not responding to the single prophylaxis, we have to add 2 drugs. Thank you.
Thank you, Dr. Maindad, for this exhaustive lecture on decompensated liver disease. So, if I may offer a comment first, and then we will open to questions. So, the liver transplants that are done in India, they are a minuscule number as compared to the number of decompensated liver diseases. So, it is estimated that just 1 in 20, less than 5% patients with decompensated liver disease will be eligible or will be able to afford or get a transplant. That means that 19 out of 20 or 95 patients out of 100 are going to require some other form of supportive care. And they are going to have need for discussion of goals of care. And so, I mean, we're towards the end of this the liver disease part of your conclave. Inflammatory bowel disease. So the comment that I'm offering is that we need to work together, the physicians at IIM,
GI conclave,
general practitioners and the gastroenterologists, to work out how we will manage these remaining decompensated liver disease. Because they are in as much need of our empathy and compassion as are the ones who are going to receive transplant. That's my comment.
So, very nice presentation. I have a couple of questions. One is, does your prescription always include a probiotic in case of decompensated liver disease? As you said, there is a lot of dysbiosis and continuous inflammation. And the second question is, how you practically advise a patient to get that sodium restriction? How you tell them in a OPD how much sodium or how much salt or which kind of salt to take, because sodium restriction is one of the major interventions.
Till now, guidelines are not suggesting to use probiotic as a regular treatment for the decompensated liver disease, though dysbiosis is one of the factor in decompensation. So we are not really prescribing it regularly. And there are nowadays many studies are coming into the picture. They says that the dysbiosis and translocation is happening, and it is the basic reason that patient further decompensation is developing. In future we will get it in a guideline, but we are not prescribing it regularly. The second your question is how to explain patient about use of salt. So many times we are advising patient to take 1 tablespoon salt, which is around 5 grams of salt, and which is approximately to the daily requirement of the sodium. Sorry, teaspoon. 5 grams. It is equal to 5 grams.
Any other questions from the audience? Thank you very much, sir, for an excellent talk.
Thank you.
Thank you, sir. May I request Dr. Raju Variani, sir, President IMA Pune, to come on to the dais. Dr. Raj Lavangi, sir, President PDA, to come on to the dais. And I also request Dr. Naurange, sir, please come on to the dais to felicitate Dr. Maindad. I request President Variani sir to felicitate the chairpersons, Dr. Padma Iyer madam. Dr. Lavange sir to felicitate Dr. Dubai sir. And Dr. Naurange sir to felicitate Dr. May I request all the managing committee members of Pune IMA to join for the photo, please. Excuse me, now Sanjay Patil sir, Sunil Ingray sir, Arti Nimkar madam, all managing committee members to join for this.
तो बाहेर एक मोठा सोफा आहे.
Thank you everyone. Let's now move to our next talk, please. To chair the next session, may I now request Dr. Amol Bape sir, gastroenterologist from Dinanath Mangeshkar Hospital, Dr. Nitin Pai sir, again from DMH Gastroenterology Department to chair the session, and Dr. Prabhakar Mahajan sir, General Surgeon, Mahajan Hospital, to chair the session, please. It's my pleasure and privilege to introduce the next speaker, Dr. Amol Dahade. He is the Associate Professor at D.Y. Patil Medical College, Consultant Gastroenterologist at Manipal Hospital, Made. He has done his MBBS from GMC Miras and MD and DM from GB Pant Hospital and Mansi, that is Maulana Azad Medical College, New Delhi. He has many publications including a textbook chapter. Congratulations. He is member of ISD, INSL, SEG, SDEI and WGO. Am I right? Over to you, sir. I request Dr. Kedar Patil sir to come over here, please.
Good morning to all. At the outset, I would like to thank for this opportunity and thank you, dignitaries. So, what's new in endoscopy? Endoscopy is a continuously expanding arena of gastroenterology, and there are a lot of new innovations, new techniques, and new procedures are being introduced day by day. If you take a gastroenterology or endoscopy journal, you will see a lot of new things coming up. In every issue, you will get something new. So we will discuss what is new in the last 1 decade. So what is currently being standard of treatment, what developed in endoscopy that led to that, and what is in the vision. So the advances in endoscopy, the major advances are in the third space endoscopy. Third space means submucosal space, which is being explored by gastroenterologists to the extent that it is currently unavailable. That was thing 10 years back. So there are many advances in endoscopic ultrasound, there are advances in bariatric endotherapy, there are advances in GERD treatment, and there are also advances in imaging enhancement, which I am not going to talk in detail, and there are advances in small bowel endoscopy as well. So we have to remember the initial development of the endoscopy. It has started in 1805. So they are very crude and primitive instruments, but over the time it has developed into what we are currently using, that flexible endoscopes. So normally the golden era of endoscopy is considered from 1968 to the 1990, because many of the procedures were introduced in this area, in this time period. The first ERCP was done in 1968, which was a diagnostic ERCP. Later on, first therapeutic ERCP done in 1974. Then first US introduced in 1980, and then EVL. So I will say the current is a new golden era for endoscopy and advances in endoscopy, because lot of new procedures beyond diagnostic has been introduced in the endoscopy arena. First endoscopic ultrasound guided ward of pancreatic necrosis drainage was done in 1998. First US guided biliary drainage done in 2001, and then endoscopic suturing equipment introduced in 2004. The first POEM procedure, that is a per-oral endoscopic myotomy, done in 2008, and first frame, that is a per-rectal endoscopic myotomy for Hirschsprung disease, done in 2016. So coming to the third space endoscopy, again the third space endoscopy has multiple applications starting from esophagus to the rectum. In the esophagus, the most common application is for achalasia cardia, what is popularly called as a POEM, for oral endoscopic myotomy. In the initial era, the treatment for achalasia cardia was surgical, laparotomy and myotomy. Then laparoscopic villus myotomy was introduced, and later those patients who cannot undergo surgery, we are used to do endoscopic balloon dilatation. But the introduction of the POEM, now this is becoming a current standard of treatment. Again, third space endoscopy is used nowadays for subepithelial tumor resection, what is called as a STIR, that is submucosal tunneling and endoscopic resection of tumor. Similarly, it has been used for gastroparesis, juncus diverticulum and esophageal stricture. We will come one by one. Achalasia cardia is a common problem, which is generally what we say, it is incomplete relaxation of lower esophageal sphincter, leading to the dysphagia to the patient, weight loss, and the standard of care, as I told, was a Heller's myotomy. But with the introduction of POEM, so POEM is a procedure done with the endoscopy. We introduce the endoscope into the esophagus, we locate lower esophageal sphincter, and then proximal to that, 15 cm proximal to that, we inject into the submucosal space. Submucosal space in GI tract is a dead space and it is expandable. There is a loose areolar tissue in that area which can be expandable with the fluid injection. Normally we use normal saline, gelofuscin, and hydroxypropyl methyl starch has also been used. After expansion of this space, we use multiple types of knife nowadays are available. Generally nowadays being used is a hybrid knife. With this knife we cut the mucosa, we enter into the submucosal space and we dissect this space with the help of the hybrid knife. Once we do the dissection till lower esophageal sphincter, that LES area, and beyond that we dissect for 3 to 5 cm more and we expose the muscle. So this is an endoscopic view of achalasia. So this is how submucosal space seen after giving cut after injection. So this is a submucosal space in figure B we are seeing, and this is being dissected. After complete dissection we can see the circular muscle fiber seen in the figure C, and then we have started doing the myotomy with the help of the knife, and this is a completed myotomy. After completion of myotomy, normally we see again go to the stomach. We see whether this myotomy is adequate or not adequate, which can be easily just by passing of the scope. And then we come back again, we again inspect the tunnel for any bleeding, and then we close the mucosal incision. So till date there are more than 10,000 procedures have been done worldwide. It is a safe, can be considered as a daycare procedure because hospital stay is less than 48 hours and it gives substantial relief. I will show you the evidence of substantial relief and acceptable rate of adverse event compared to the surgery. And nowadays the technique is standardized and it is with help of technical advances, and with the equipments, it's a completely standardized procedure, and now enough technical and clinical expertise available in this area. So this is a selected studies in which you can see the patients who underwent POEM, the treatment success rate is almost to the 98%, varying from from 85 to 98%, and the complication rate is from 2 to 13%, which is acceptable. And if you see the most dreaded long-term side effect considered is reflux, the figures vary between from 5 to 30%. We'll come to that again. So there are multiple studies done which compared POEM with laparoscopic Hall's myotomy, and in this we can clearly see if you take a dysphagia as outcome, the POEM is favored over laparoscopic Hall's myotomy. Again, if we see the Ecart score, which is a dysphagia score used in achalasia patient, it definitely favor POEM procedures over laparoscopic Hall's myotomy. Again, the complication, if we see the GERD, because normally in POEM we don't do the fundoplication, which is a normally additional procedure in the laparoscopic Hall's myotomy. So this was touted as a dreaded adverse event for the POEM. But if we see if the subjective criteria used in study, according to the subjective criteria, it favors POEM. But if you use objective criteria like 24-hour pH-metry, it favors laparoscopic Hall's myotomy. It means that symptomatic GERD incidence is equal in POEM as well as laparoscopic Hall's myotomy, though subclinical GERD may be present more in patients who underwent POEM, as we do not do fundoplication. So to tackle this side effect, again POEM with fundoplication being introduced as an additional procedure, because we can access peritoneal space after doing myotomy from the stomach. And this is a depiction of one POEM plus fundoplication procedure in which the endoscopist enter into the peritoneal space after doing myotomy. We locate the posterior wall of fundus with the help of another endoscope, which goes into the stomach with translumination, and we do the fundal wrap with the help of the hemoclip and the endoloop, which is tied to the cut myotomy edges. So this study is done from Pune only by Gopaya sir, this POEM plus fundoplication study, and you can see the result over the 1 year. The additional procedure time is hardly 45 minutes, and the fundoplication success rate is 92%, and the adverse event rate is only 12%, which is acceptable. So we can see the long-term clinical success rate is 89%, and the intact wrap can seen be in 83% patient. So this procedure can replace, especially in the younger patient who are more feared for their GRD. Again, this is a new procedure, that is a per rectal endoscopic myotomy, and again first procedure is done by Gopaya sir only in Pune, and this is done for Hirschsprung disease. Over the last 30 to 40 years, for Hirschsprung disease, the procedure, choice of procedure is a multi-stage surgery, Duhamel surgery. But this carries a significant morbidity. Also, the patient may have risk of colostomy, and few patients have risk of incontinence. So the same principle of submucosal dissection and myotomy, like achalasia cardia, is being applied here, with submucosal dissection being done in the rectum, and the myotomy is done in the selected area, which is selected by multiple biopsies from the rectum prior to this procedure to delineate the aganglionic area. So again, coming to the role of the POEM in gastroparesis patient, this is a very common in especially diabetic population. Again, our understanding of gastroparesis is not that level as of now also. It is a still evolving entity, but POEM definitely has a role in a gastroparesis patient. The same principle applied like achalasia cardia, where the target is the pylorus. So we go into the stomach, we start from the dissection into the distal body, and we go to the across the pylorus, and we do the myotomy, and then we close the mucosal incision. So there are multiple studies published for gastric POEM also. So total in this review there are total 269 procedures were reviewed with technical success rate of almost 77%. The most common cause of gastroparesis in this study, review was idiopathic, followed by diabetes mellitus, followed by post-surgical. The adverse event was only 6%. If we see the gastroparesis cardinal symptom index score, it is definitely favors the G poem, and there is a significant improvement in gastroparesis cardinal symptom index score in such patients. So another application of third space endoscopy is a submucosal resection of tumor, what is called as a STIR, that is a submucosal tunneling endoscopic resection. So it is generally the most of the procedures till date are being carried out for more of a benign tumor, but I think eventually it will go for malignant tumor also, depending upon the nature of the tumor. But most of the tumor can less than 2 centimeter size can easily removed with this technique. The technique remains same. We locate the submucosal tumor, we dissect around the tumor, and we dissect above as well as below the tumor, that is just below the mucosa, and we dissect the submucosal space along the circular muscle fiber, and we remove all the tumor in situ, and then we close the mucosal incision. So the technical success rate of this STIR procedure is almost 78 to 94%, and adverse event range from 70 to 42%, and the most common the lesion in this review was leiomyoma. That is again also most common lesion, submucosal tumor, generally found in the esophagus and stomach as well. So this is another extension of third space endoscopy, that is a per annal endoscopic myomectomy. So the few patients who is having mucosal and submucosal tumor have extensive fibrosis in the submucosal space, and that leads to the difficulty of the dissection along that plane. So if there is a difficulty in dissection along that plane, we can remove the circular muscle fiber as well, leaving behind only longitudinal muscle fiber. Obviously this is too early to say this will become a routine procedure, but definitely this is a proof of concept. Again, extensively use of this third space endoscopy in a Jenker's diverticulum. Often these patients are old age and they are difficult to treat with the routine treatments. Routine treatment are being done is septostomy by either flexible endoscope, rigid endoscope, or surgical septostomy. Given the old age and multiple comorbidity for this patient, this all procedures become difficult and there is always risk of a leak. So the poem concept can be applied for this Jenker's diverticulum, and we can cut the septum and then we can close the mucosal incision, and you can see on this barium that patient is taking barium and it is going freely. So far there are total 11 studies with 355 patients with technical success rate of 96% and clinical success rate of 93%, and adverse event is 12%, which is acceptable, and recurrence rate can be seen 11%, similar like the previous modalities. The similar concept can be applied to the diverticulum, especially epiphrenic diverticulum, which causes dysphagia to the patient. The same principle like Jenker's diverticulum being applied here. So this is a depiction of peroral endoscopic tunneling and restoration of esophagus. This is being used in the refractory esophageal strictures which are not amenable to dilatation and recurrence. So this is again difficult procedure to do. It requires high technical expertise, but with some additional techniques like using transgastric approach as well as antegrade approach, that is from above downwards, the procedures are being done, and few case studies has been being published and it found to be effective. Again, endoscopic submucosal dissection is a boon for early esophageal stomach as well as colorectal malignancy. This is also being very useful in the polyps, which are generally sessile polyps and large polyp, which have always have fear to have some deep sitting malignancy which cannot be detected earlier with normal routine biopsies. So this patient can be directly subjected to the endoscopic submucosal dissection and in situ removal of that tumor. The concept is similar of like third space endoscopy, where we create space in submucosal space by injecting, and then we remove a tumor in situ. Like depicted in this diagram, that this is early stomach cancer. The incision is given, submucosal space is dissected, and this whole early stomach cancer is being removed. So there is a lot of data has been published in the ESD, and they have shown overall en bloc resection is 91% and R0 resection rate is 82.9%, which is very good. This is a new tool developed for this small tumor which can be resected with endoscopy in one setting and required less technical expertise. So this is a full thickness resection device in which there is a clip loaded and snare loaded to the endoscope. We go near to the tumor, we suck the tumor into the tunnel, and then we apply the clip. Once clip is applied, the tumor is resected with the preloaded snare. So here the risk of perforation is minimum, and it is a technical, it is less technically demanding than ESD. Coming to the another area where a lot of advances has been happened to the endoscopic ultrasound. Nowadays it is an established modality for diagnosis of many pancreatico-biliary diseases, and it is routinely being used for sampling like malignancy sampling, mediastinal lymph node sampling. So again, ward of pancreatic necrosis and cirrhosis drainage, nowadays it is a standard of care, followed by it has been now being used for routinely for biliary and gallbladder drainage. It is being used for gastrojejunostomy. It has been also being used for pseudoaneurysm treatment, and it has been being used nowadays for ablation of pancreatic tumor. The celiac plexus neurolysis, it has been also being used since many days. So I will just skip this slide. I think it will be discussed in pancreatitis. But these randomized controlled trials, one is a Panther trial, another is a Penguin trial, which establish firm role of minimally invasive approach, and endoscopic approaches are better than surgery in the pancreatic collections. So the endoscopic ultrasound guided drainage procedure has evolved over the time, over the last 20 years. So initially it has been done by with side viewing scope. Later on, when endoscopic ultrasound was introduced, it was routinely used because endoscopic ultrasound can avoid the bleeding complication. It can locate the vessels and you can target the area accordingly. Again, the patient who is having collaterals, because splenic vein thrombosis is a very common complication in pancreatitis, where it is difficult to do routine cystogastrotomy even by surgical means. So in these patients, endoscopic ultrasound is a boon. So initially we are being used plastic stent, and nowadays there are dedicated metal stents are being developed, and they are already in market, and we are being using it for the drainage. So there are multiple studies comparing plastic versus metal stent, one from Pune itself, and it has shown that metal stent is superior to the plastic stent for pancreatic collection drainage. So this is a newer development in stent itself. It is a one-go stent where cautery is enabled in with the stent itself, and it reduces the time, overall time for the procedure, and also it enhances the technical success rate. So US guided gastroenterostomy, that is a US guided GJ, is coming, and nowadays people are using it. So it is with help of endoscopic ultrasound, we have to locate a jejunal loop. Once we locate jejunal loop, we inflate that jejunal loop with fluid with a special balloon called as EPAS balloon. And even if we don't have this EPAS balloon, we use another balloon, or we can continuously inject water into the jejunum to keep inflated that loop, and then we can puncture with the jejunum through the stomach, and then we can deploy the stent, metal stent across that, and it is we have to dilate that tract after deployment of the stent. So this is comparatively easy, especially the highly morbid patient like malignant patients, and as efficacious as surgery. So technical success rate is touted almost 92% for this procedure, with clinical success rate of 90%, and the adverse event rate is 12%, which is acceptable. So again, US guided coil and glue placement are now being used for gastric varices. Sometimes gastric varices are difficult to treat with endoscopy, especially when there is a large size of varix. They do rebleed while you inject glue through the endoscopy. And also in the patient where there is a high embolization risk, the US guided coil and glue placement is superior to routine endoscopic glue placement. So there are total 536 patient data available and almost 100% technical success rate with 97% clinical success rate. Again, we are endeavoring into the pseudoaneurysm. So gastric artery, splenic artery, gastroduodenal artery. So these arteries are in the vicinity of endoscopic ultrasound. And the pseudoaneurysm development is most common happen in this area, generally because of chronic pancreatitis or maybe due to other diseases. And with the help of endoscopic ultrasound guided, we can target the aneurysm, we can puncture it, and we can deploy coil like intervention radiologists deploy with the similar. Along with that, we also inject thrombin. Some people also use cyanoacrylate glue to further increase the effect. So there is only handful data, but it is a useful procedure only in case series, and almost 90% clinical success rate has been shown in published data. So this is being coming in a big way, that is a US guided tumor ablation, and porcine studies done in 2012, and it is a safe and effective method of tumor ablation, especially small size tumor, generally less than 1 centimeter, especially the neuroendocrine tumor in the pancreas which are functional. This method is very useful and having touted as a very high clinical success rate. Last year only one large study is published in scientific report, and they have used the similar method in unresectable adenocarcinoma of pancreas and periampullary carcinoma, and they have shown that there is increased survival. So almost 189 patient data available with 94% clinical success, 94% technical success rate and 85% clinical success rate. Again, celiac plexus blocks are advised for the chronic pancreatitis patient and the patient who is having GI malignancy with intractable pain. And endoscopic ultrasound can locate the celiac ganglion in most of the patient, and when you are not able to locate it, you can identify the location of the celiac axis, and you can directly inject. Normally we use bupivacaine, triamcinolone and absolute alcohol either for neurolysis or block. And the efficacy is 70 to 80% in malignancy and 50 to 60% in chronic pancreatitis with side effect less than 1%. Again, coming to the gastroesophageal reflux disease, we routinely see in our routine practice, and almost 10 to 40% patients are refractory on routine PPI treatment. For this patient, normally we advocate surgery, that is fundoplication, but endoscopy is coming here with big way. There are two type of methods currently now being used. One is a transoral incisionless fundoplication, and another is a radiofrequency ablation of lower esophageal sphincter and augmentation. So this is a transoral incisionless fundoplication by and catheter of called as a esophytes, and this is a catheter in which there are tuck sutures. You can see it here, and it has to be done by two people. One person shows the endoscopic view and another person operates this catheter, and over the 200 to 300 degree we apply this suture, and it just is like similar doing surgical fundoplication. So this is another instrument introduced, Medicus ultrasonic surgical endostapler, in which we actually fire a stapler, and it is being done by only one person. So this is slightly touted as a better instrument because less persons are involved in this, but again it is not available. It is more of in few countries, in Germany it is available. Again, the studies for trans oral incisionless fundoplication, so you can see almost esophagitis healing can be seen almost average 75% of patient, and troublesome regurgitation is also can be seen eliminated almost in 75% of patient. Again, coming to the strata procedure. In strata procedure, we insert a radiofrequency catheter. That is actually balloon which we insert under endoscopic guidance, and once we locate lower esophageal sphincter, this catheter has radiofrequency needles which come out of that catheter, and we apply radiofrequency at that area, and it augments lower esophageal sphincter, just behaving like a fundoplication. So small amount of data available in strata procedure as well, and it definitely shows there is improvement in GRD, health related quality of life in this procedure. Again, just 1 or 2 slides for this obesity. Again, obesity is a pandemic, and balloons are, since they are used since I think last 15 years we are using balloons, but balloons are the only bridging therapy and they are not considered as permanent. Also the side effect rate is higher in cases of balloon. That's why they are only used for generally 6 months to 1 year, and average observed weight loss is a 10%. This is again a very good modality for bridging therapy, as some people cannot undergo the bariatric surgery upfront. So now there is a time for endoscopic sleeve gastroplasty. Once the endoscopic suture needle was introduced by Apollo, so this has become a reality. And nowadays our endoscopists are doing endoscopic sleeve gastroplasty, in which we take suture from inside stomach from down to upward size, and we convert the stomach into the narrow tube, which reduces overall surface area of the stomach and just behave like a surgical sleeve gastroplasty. So till there are 1,700 patient data is available. Over the adverse event rate is only 2.2%, which is acceptable. Among these studies, only 4 studies have observed people for almost 2 years, and they have shown that total body weight loss is seen almost from 15 to 20%, which is a significant. So there are so many new modalities which are coming up. Artificial intelligence, everyone knows now, ChatGPT. Artificial intelligence is coming big way in endoscopy. If you pick up a journal, you will see at least 2 or 3 publications regarding AI in every medical journal, I guess. So artificial intelligence being used in colonoscopy, it is available in the market. Artificial intelligence is being used to predict whether which CBD stone is difficult to remove from endoscopy. It is also being used to predict the nature of the tumor which you are going to remove by ESD or by another method. So it is coming big way. Again, there is a big development in small bowel endoscopy, the spiral motorized endoscopy being introduced. There are already double balloon endoscopy and single balloon endoscopy available for small bowel enteroscopy. But the advantage of spiral motorized endoscopy is that it cuts short the time to almost 70 to 80 minutes, which was previously being 2 to 3 hours for normal enteroscopy. Again, the image enhancement techniques are coming in big way, and I think in few centers this type of machines are available, what we call as a confocal laser endo microscopy, in which on endoscopy itself you can predict the histology of that abnormal mucosa or the abnormal lesion you see. Again, spyglass is there since a long, but I think the use being increased since last 5 to 10 years in big way, and the large difficult bile duct stone are being removed endoscopically only with help of laser with spyglass, and also spyglass being nowadays being used for even for pancreatoscopy and for pancreatic stone removal also. So from you. Thank you very much.
Congratulations, Amol, for an excellent review, and thank you for including our Pune studies. So, any questions from the audience? Yeah, Kedar.
Quite common in practice is present with dyspepsia. So for this procedure, how are you choosing these patients? And the next would be, in bariatrics we see when the pyloric function is lost, there is dumping. So are you seeing dumping with this procedure?
Okay, so see, in diabetics it is a mixed pathophysiology actually, where gastric contractility is also affected and there is pylorospasm. So we have to confirm that pylorospasm is the primary cause for the gastroparesis before offering GPOM to these patients. So we do it in multiple ways. We give them a trial of prokinetics, or we can even do a balloon dilatation of the pylorus, which may give a transient response before actually subjecting them to GPOM. Because otherwise, if it is only a gastric contractility issue, then they may not respond. And dumping usually is not seen that much with GP. So probably dumping occurs more often if there is the duodenum is bypassed. Here we are not bypassing the duodenum, so dumping is not commonly seen.
Radionuclide studies, do they help in selecting these patients?
Yeah, gastric emptying studies have to be done, and anything beyond, grade 2 or grade 3 gastroparesis or grade 4 may benefit. Grade 1, grade 2 should not be offered gastroparesis, but modulation, lifestyle modulation and pharmacotherapy is better for them.
There is new technology being introduced called as electrogastrography nowadays to identify the patient who is having poor gastric contractibility. Like by Sir said, we have to select the patient who have a dominant pylorospasm. Those patients who are having absent gastric contractibility, they respond obviously poorly despite doing GPO.
I think apart from that, there is another new technique which we can do is something known as endoflip. It's being studied, and I myself have done study in pylorus distensibility on the using endoflip, but unfortunately that's very costly as of now, not available outside the clinical trials.
Thanks. Nitin, you have. Well, we proposed this procedure about 7 years ago, and we've done about 20 odd patients, and the results are very gratifying, and even the long-term results, 7 years, they are very gratifying. We are doing a quality of life, analysis presently, which we will publish, very soon, probably by end of this year. So the results are very gratifying. So we do propose. So we are talking to pediatricians, we are talking to pediatric surgeons that they should consider for short segment, ultra short segment at least, that it should be done.
Volka, will you please elaborate something about capsule endoscopy and node surgery?
Okay. Capsule endoscopy, I think we are routinely using for small bowel imaging. And yes, I haven't covered it in this talk. And there are now capsule endoscopy, I think cost is roughly 40,000-50,000 rupees. And there are multiple capsules available in the market which can cover 360-degree areas. Initially there was capsules which are only covering 180-degree areas. But again, capsule gives you diagnosis in 85% of patients. 15% area can still be missed by capsule endoscopy. But it is main indication still remains as an obscure overt GI bleed. In this patient, if we are not able to identify through upper GI endoscopy, colonoscopy and CCT abdomen and angiography, after that generally we go for capsule endoscopy to identify the site of the lesion. And natural orifice surgery, yes, it is being, again it is another adventure, as we say, I say gastroenterology in its adolescence. So we are doing adventures, so many adventures. So it has been used for, people are doing even cholecystectomy by going into the peritoneal space and appendixectomy. So, no, not practice actually.
Any other question?
So I think it's been a lovely deliberation, and thank you Amol and for a lovely audience also, and Dadasaheb for pulling up an amazing conference. Yeah, congratulations to everyone.
Thank you, Dr. Amol. May I request Dr. Raju sir, President IM. I also would like to invite Dr. Sudhir Kothari sir, the senior surgeon, for the felicitation over here on the stage, please. Dr. Amol Bambe sir, Dr. Pai sir, Dr. Mahajan sir, please join. I would like to request Dr. Varyani sir to felicitate the chairpersons, please. Dr. Pai sir. Dr. Mahajan sir. Dr. Amol Bhatia sir. I request Varian sir to felicitate Dr. Kothari sir. Now we are going to have the panel discussion. So I request the moderator for the panel discussion, Dr. Nitin Jagtap sir, to come onto the dais. The panelists are Dr. Vivek Murumkar, Dr. Aditya Kulkarni, Dr. Varun Khandagre, Dr. Prashant Jain. I request Dr. Kedar Patil, Honorary Secretary of IMA Pune, to come to conduct this panel discussion, please.
Rakesh sir. Rakesh.
For the panel discussion, we have with us Dr. Nitin Jagtap.
कार्यकर्ता म्हणजे आता बसलाय, हल्ला पण नाही तू मगापासून, जाऊन येतो थोडंसं म्हणजे जाऊन. मी पण जसा बसलो आहे खुर्चीत हल्लोच नाही. नाही नका करू नाही पोहोच.
Till they are making the arrangements, I once again remind all the delegates, those who have registered for today's CME will get our next month's CME complimentary. That is on 18th of June, and it's about the newer horizons in medical services, where all the recent advances in the medical therapy will be discussed. The detailed program is being kept down at the registration counter. Another thing is our online hypertension course by IMA Pune is starting on 17th of May. That is the World Hypertension Day. It will be only 2:30 to 5:30 every Saturday online. So already there are a lot many registrations. Those who wish to register, today is the day, because already the fees have gone to 10,000, but today we are giving all the delegates who are registered here at 8,000. So I request all of you to take the advantage of that. So I request all the panelists to come on to the dais, please.
Let me introduce the panelists. The moderator for today's session, Dr. Nitin Jagtap. He is an surgical gastroenterologist at the Pioneer Institute in GI in India, the Asian Institute of Gastroenterology situated in Hyderabad. And his area of interests are bariatric surgery, bariatric endoscopy, non-alcoholic fatty liver disease, ERCPs. He has numerous publications and is a scientific member of the national and international endoscopic societies. We also have with us panelists Dr. Aditya Kulkarni, who's a surgical gastroenterologist at Ruby Hall Clinic, and he is interested into minimal invasive surgeries and abdominal malignancies. We have Dr. Varun Khandagre, who is a hepatologist, gastroenterologist at Inlax and Budrani Hospital. And he is a member of Indian National Association of Study of Liver with more than 8 years experience and many publications. And finally, we have two more experts in this field, Dr. Vivek Murumkar, who is a gold medalist MD radiologist from the GS Medical College, and he's an intervention radiologist at KEM Hospital, studied at KEM Hospital Mumbai, AIMS Delhi, and is a panel consultant at Ruby, Sahyadri and Noble group of hospitals. And to support all of them, we have Dr. Prashant Jedge with us, who is an intensivist at Bharati Vidyapith Medical College. So may I hand over the proceedings to the panelists.
Thank you. I welcome all. So we'll start with the case. So this is 39-year-old male with history of alcohol abuse and presented with severe abdominal pain radiating to back associated with vomiting since 6 hours. And on examination, he is restless with tachycardia, tachypnea. Blood pressure is around 110/70 and there is a 101 Fahrenheit temperature. So I'll ask my colleague, medical gastro colleague Varun, what are your differential diagnoses for these cases?
As the history suggests, the patient has severe pain in abdomen. You can get the previous slide. Severe pain in abdomen, recent history of alcohol misuse with vomiting, tachycardia, tachypnea. The differentials can be many different things. First, most common will be, I would say, peptic ulcer disease, followed by, if you consider severe cases, it can be pancreatitis, it can be bowel ischemia, it can be bowel perforation, or some other causes like gallstone causing cholangitis, or in rare causes like mentioned, it can be myocardial infarction also.
So what can be the differential diagnosis which can be divided into abdominal and non-abdominal, and non-abdominal one need to understand which are myocardial infarction can present as epigastric pain with vomiting, pneumonia, sickle cell crisis and diabetic ketoacidosis. So I asked Dr. Aditya, what are the surgical emergencies possibly can present with this presentation? Acute onset pain abdomen.
So we always have to keep the possibility of a perforated peptic ulcer, although it is uncommon in today's era. Still a perforated gastric or a duodenal ulcer can present like this. We have to keep in possibility, keep the possibility of bowel pathology like bowel ischemia or bowel obstruction. Severe complicated gallbladder disease can also present with epigastric pain and vomiting. So acute cholecystitis or gallbladder empyema or perforation can present.
So this patient underwent evaluation and his amylase lipase were elevated, and there were ultrasound was showing there is a peripancreatic edema. So the diagnosis was established as acute pancreatitis. So Dr. Varun, what are the common causes and uncommon causes for acute pancreatitis?
Commonest cause in today's era, what we see are first two are alcohol and gallstone disease. Apart from that, in clinical practice, we see hypertriglyceridemia as a common cause. Then there are multiple viral infection, drug-induced pancreatitis, some other etiology like hypercalcemia, trauma, genetic interventions.
So as I told, the lab investigation showed WBC counts on higher side. There is raised BUN, raised creatinine, mildly deranged LFT, and amylase lipase is more than 1000 and 2300. So at this point, we need to understand which patient required emergency care or critical care, and which patient can be managed in ward or outpatient. So this is very interesting score which can differentiate patient from who require intensive care versus who don't require intensive care. And this have three components, which is called harmless acute pancreatitis score, no rebound tenderness or gardening, normal hematocrit and normal serum creatinine. HAB score within 30 minutes of presentation can enable us to identify patients who are more likely to run a milder course of the disease, and it's having 98% accuracy to predict the patients who don't require ICU admission. So if the patient is having these three
parameter fulfilled, this patient may not require a critical care admission. As we have seen, this patient has high creatinine, so he is not fitting into this criteria. So this patient required initial critical care management. So I asked Dr. Prashant, what are the initial algorithm that he can follow for these patients with acute pancreatitis in day 1 to like in first week?
Can we have the investigation slide? If you look at this, he's an alcoholic. To have an 18.7 gram, definitely he's dehydrated, and that is the role where the fluid resuscitation comes in mind. So when we discuss about the fluids to be used as the drugs, so we need to answer a few questions. Why we require drugs? So why we require fluid? It is to maintain the perfusion to the organs, which are the more important in these scenarios is the kidney, brain, and the heart. Then the question comes, which fluid? So most commonly, most of the times it is the Ringer's lactate is the fluid of choice, unless your etiology is hypercalcemic pancreatitis, where the fluid will be normal saline, because Ringer lactate itself has got calcium content. After why and which is how much to give the fluids. So how much to give the fluid, there is no holy grail answer for that. Before this waterfall trial, the aggressive fluid resuscitation was the key in pancreatitis, because these were the dehydration. There is lots of third phase loss. But after this trial, we have come down to less aggressive fluid resuscitation. That is around, you start with the bolus around 10 ml per kg, and maintenance after 2 hours, the maintenance is around 1.5 ml per kg. And at the same time, see your target endpoints and the safety endpoints. The safety endpoints are crucial, because if there is a worsening tachycardia, worsening desaturation, and there are new signs of development of fluid overload, we have to stop the fluid resuscitation. And our target endpoints will be decrease in tachycardia, improvement in the fluid, improvement in the urine output, and improvement in the mean arterial pressures. So this is how, and how to give the fluids, probably 2 large bore IV access, and central line is not required at this moment. With 2 large bore IV access, you can continue with the fluid. So this is how we answer why, which, how, and how much to be given, and what to look for regarding the fluid.
Thank you. So coming to the next part regarding imaging. So I'll ask Dr. Vivek when and what imaging he will prefer for this patient in first week of illness.
Actually, the history-wise and the marker-wise, it looks like a case of pancreatitis. So ideally, we have to differentiate between 2 types, such as edematous kind of pancreatitis or necrotizing. So on CT, we can diagnose necrotizing pancreatitis with very reliable information. So if any part of pancreas is not enhancing, or it's enhancing less than 30 HU as compared to normal pancreas on venous phase, then it tells about necrosis. Similarly, in that same time, we can assess any peripancreatic collection is happening. If it is necrotizing, we call it as APFC. If it is an edematous pancreatitis, we call it as APFC. And if it is a necrotizing pancreatitis, we call it as an acute necrotizing collection. And in this particular case, CT has to be done. The necrosis in early phase is difficult to tell. So typical time we say is day 5 to day 7 for the imaging. So at the day 5 to day 7, if you do CCT, we can diagnose necrotizing pancreatitis with very much great confidence.
One thing which I would like to mention for all the people who come into contact with contact with a case of acute pancreatitis, one of the most common errors what we make is doing a CT scan too early in the course of the illness. Many a times this also tends to exacerbate the acute kidney injury that these patients have in the early phase. And this scan is not going to correlate at all with the course of the illness, because the necrosis has not had time to happen yet, or rather it cannot be picked up yet. So as sir said, the ideal time is between day 5 and day 7, but many a times we find that the CT is done earlier. So we can probably skip this CT early in the course of illness.
So cross-sectional imaging, particularly CT scan, if you want to do in early stage, it's to rule out any other illness if you are suspecting, such as ischemia or bowel perforation, not to diagnose or quantify acute pancreatitis. So we coming to next question, how do we define severity of acute pancreatitis?
Severity of pancreatitis, we have very fine classification by Atlanta that is divided severity into 3 types: mild, moderate, and severe. Simple mild is no organ failure or no local or systemic complication. Just patient presenting with abdominal pain, raised amylase lipid levels, no organ failure like respiratory failure, kidney failure, or heart failure. Moderate is patient has transient organ failure that is less than 48 hours. So initial patient came with hypotension or low SpO2 level who needs oxygen supplementation that lasted only for or recovered within 48 hours, that is transient organ failure, or when some or the other local or systemic complication. Severe pancreatitis is that organ failure persisting more than 48 hours. He is needing oxygen or support for with inotropic support or any other support for kidney for more than 48 hours of his hospitalization. That is severe pancreatitis. That is the Atlanta classification.
So we'll come to the next point, to how the radiologist should report or tell about the pancreatitis. He has briefly, Dr. Vivek has briefly explained about this thing. So this is one of the patient CT scan, which can you?
Basically, this is a contrast CT taken in the arterial phase. We can see there is an intense enhancement of the aorta. Splenic artery is enhancing, but anterior to the splenic artery, which sir has pointed by the arrow, that is the pancreatic tissue which is crossing the midline. And we can clearly say pancreas is not enhancing at all. So definitely it is going towards a necrotizing kind of pancreatitis, but in given slide there is no fluid collection around it. So probably we can just say it's an acute necrotizing pancreatitis, but no peripancreatic collection around it. And we would like to see the venous phase for any venous complications like portal vein thrombosis, splenic vein thrombosis, and we would like to scroll this. So this is a pancreas basically, and this is splenic artery, this is the aorta. Aorta is showing great enhancement, so it's probably a late arterial phase, that is pancreatic phase, and this is a non-enhancing pancreas. And you have to analyze for the fluid collections also. So entire abdomen has to be scrolled, and if there is ascites, pleural effusion has to be reported from our side.
So these are two different images. This are showing a large necrotic collection, and after 2-3 weeks there is formation of wall, and still it don't look like a well-defined wall, but over a period of 3 to 4 weeks there is usually wall formation, and what we diagnose these collection as wall of necrosis. So this can be defined into, if it is less than 4 weeks in patients having acute interstitial pancreatitis, it's called acute peripancreatic collection, and after 4 weeks once the wall is formed, it's called as cirrhosis. Compared to in acute necrotizing pancreatitis, it's acute necrotic collection before 4 weeks and wall of necrosis after 4 weeks when the wall is formed and with having significant debris. And the terms such as acute cirrhosis, pancreatic abscess, phlegmon should be discarded from the literature. So coming to the next point, I'll ask my both colleagues, Dr. Varun and Prashant. So during managing these patients, what are the scoring system that we follow to define patients into quantify the severity of pancreatitis?
There are multiple, as you can see on the screen, there are multiple complicated scoring system for pancreatitis. Many of them serve purpose for exam viva, but nobody uses them in clinical practice. But there are some simple scoring systems. That's the thing actually. It's very difficult to practice, but there are some simple scoring, like we can see BISAP score, BISAP. The name is bedside index scoring for acute pancreatitis. Very simple 5-parameter calculation, and the name itself indicates the parameter. B is blood urea nitrogen, I is impaired mental status, S is presence of SIRS, A is age more than 60, P is pleural effusion. This score is simple to calculate, can be calculated bedside by anyone, even a resident can also calculate it. For research purpose, I can explain it in detail. There are great scoring systems like Ranson and Glasgow and Apache.
Ranson and Glasgow, the main disadvantage is it has to take multiple laboratory parameters in play, and it has to be done at the 0 hour and 48 hours. So that becomes a big lot of window. In ICUs, even though we use Apache score, which is not specific for pancreatitis, but it gives a complete acute physiological status with comorbidities. That's a overall use. That's a score which is overall used to understand the mortality. In ICUs, so at the emergency level, as initial slide mentioned, AB score. After having an AB score, severity is more, we take it to the ICU, we do the Apache score, and as we go on, daily we assess for the SOFA score. SOFA is sequential organ failure assessment. So it constitutes 6 organs, and each organ has got a maximum 4 points. So maximum of 32, and daily we assess the SOFA to see how much organ improvement is there. So that gives an idea about the severity of illness, apart from these routine scores in pancreatitis.
So BISAP is the best thing to do in routine clinical practice. I have another question for Dr. Prashant. When we are managing organ failure associated with pancreatitis, is there any difference when we see organ failure in, suppose, in poisoning associated with pneumonia compared to the pancreatitis? Is there any difference in the protocol?
Not much, but with pancreatitis, as I mentioned, there are 6 organs to look into. That's heart, lung, kidneys, liver, brain, and hematological. In pancreatitis, what we expect more worsening is in renal, respiratory system, because pancreatitis is one of the common cause of secondary ARDS, and cardiovascular, because of there is a third spacing, lots of fluid resuscitation, there is a hypoperfusion and hypotension. So we look into these parameters more frequently. Since one of the causative reason is alcohol, the pre-existing liver dysfunction can give rise to the hepatic failure also.
So one more point I like to highlight, that suppose something like pneumonia or poisoning, there are antidotes or specific therapies available for that, as compared to pancreatitis is none, unfortunately. So that then we come to our next question: what are the possible drug targets which are studied in the past for management of acute severe pancreatitis? So Dr. Varun, can you highlight on this?
Actually, pancreatitis being a dreadful disease, lots of studies have been done regarding different agents which can improve the course of illness, but sadly there is no single drug or antidote for this illness. Very commonly what we see in each and every hospital around the country is use of somatostatin or octreotide in patient pancreatitis, but sadly it's not been recommended by any guidelines. It doesn't affect the mortality of the patient. In some patients it may improve the course of illness. Only indication to use somatostatin, known indication is ductal disruption. When there is leakage from duct, then you can use it safely. Other antioxidant, aprotoniin, calcitonin, hormones, glucagon, NSAIDs, other lexicofans were used, but they don't improve the short-term or long-term mortality of the patient. And these studies were very low quality studies with no consistent clinical benefits.
Yes. So majority of drugs which are prescribed, such as octreotide, somatostatin, calcitonin, anything else that don't work in pancreatitis, don't increase the bill of patient by using this type of medicines. So next best thing for pancreatitis, yes.
One thing which probably we don't address very frequently is the pain management in acute pancreatitis. And these patients have severe pain, and many a times the hemodynamics are altered by this pain also. So what we can do is, some of the opioid analgesics are also safe in acute pancreatitis, but epidural analgesia or some aggressive form of pain management should also be pursued to make these patients comfortable.
So next part is nutrition. So first part is pain, that's discussed by Dr. Aditya. Another part is nutrition. So enteral nutrition is considered better as compared to parenteral nutrition with respect to complication, need for surgery and mortality. It has shown that enteral nutrition reduces this risk. However, there is no difference between nasogastric and nasojejunal tube, but majority of gastroenterologists do nasojejunal tube to avoid the risk of aspiration. The Python trial has shown that early enteral feeding within 24 hours versus demand feeding after 72 hours has no difference in required antibiotic. Even same for probiotics. The procalcitonin level can be considered as best biomarker for detection of early infection, and particularly if the levels are persistently rising. So this patient has come up, managed his AKI, ALI, and now he is having persistent SARS in 3rd week. So is there any role for early intervention? I'll ask my intervention radiology colleague, Dr. Vivek and Dr. Aditya. Is there any role of early intervention that's before 4 weeks, means before the development of one?
Actually, if patient, it depends on patient condition. If patient is having persistent fever, race count, race CRP and procalcitonin levels are high, or patient is going towards the organ failure or new onset organ failure, or the collection is causing some extrinsic compression on the gastric outlet or in bowel or biliary compression, then definitely we have to intervene on the early stage. You have to drain that fluid either by USG guidance or either by CT guidance.
Speaking broadly, it is always better to delay the first intervention as much as possible. The first intervention previously used to be surgery, and it was a nightmare surgery. Before 4 weeks, when the necrosis is not encapsulated, there is a lot of bleeding. We end up resecting a lot of pancreas, which is actually viable. So we are going more towards the first intervention being either a pigtail drainage or an endoscopically placed stent. So either way, it is always better to delay as much as possible, at least beyond the 3rd week and ideally into the 4th week of the illness. So because there are studies and pooled analysis from a very large number of patients, the first intervention when it is done as late as possible, so we have actually lesser mortality and less incidence of complications.
So the majority of literature in publication come from the Dutch pancreatic group, and they recommend 3 Ds of acute severe pancreatitis, which is delay as much as possible, then drain with PCD, and then debride. Okay. So early intervention for acute necrotizing pancreatitis is associated with higher mortality rates and do not reduce the adverse events or improve clinical success. So better to delay till the wall is formed, so that any surgery or any intervention is simple. So once the patient develop acute, has recovered from this 4 weeks and developed acute walled-up necrosis, what are the next possible treatment options? That will be decided. For that, I'll ask Dr. Aditya to tell us about what is the so-called step-up approach for necrotizing pancreatitis.
So in the past, the occurrence of infected pancreatic necrosis meant only one thing, that the patient has to undergo a surgery and we have to remove the necrotic part of the pancreas, drain all the collections and deal with whatever pathology is there inside surgically. You can imagine that these are very sick patients, and doing surgery in them is always going to cause a large amount of morbidity and mortality, almost to a tune of 30 to 40% in the old study. Now this trial came in late 2000s, I think 2008 or 9, and this was one of the landmark trials. This is the Panther trial by Dutch Pancreatitis Study Group, and they showed that instead of directly going for a surgical approach, we can first sort of delay the intervention by draining the focus of sepsis, that is a purulent pancreatic collection, by doing a pigtail. And in fact, they found that almost 35%
approach in which PCD first versus surgery first. If you do PCD, there is chance that 35% of patients don't require surgery. So there are 2 types of step up. One is endoscopic step up and surgical step up, and this again a Dutch pancreatic group study. I would like opinion of Dr. Varun and Aditya regarding this study, tension trial. So this
regarding endoscopic step up, as Aditya rightly mentioned, we start with minimally invasive approach, that is endoscopic approach, for the collection of lesion or the walled-up necrosis lesion which are near the lumen, that is periduodenal or perigastric, we try to approach them by endoscopically. Endoscopic ultrasound guided drainage is done. Then endoscopic ultrasound guided necrosectomy or irrigation is done for lesions which are near to lumen. Lesions which are away from lumen, that is distant collection, they are drained percutaneously. And repeat within like 30 to 40% of patients, we don't require any other procedure. Those patients who are not settled clinically or those patients who develop new symptoms, in those we need to step up the procedure, either repeat endoscopically or with surgery.
So what they try to look at is they sort of try to pit surgery versus endoscopy one-on-one against each other and see how the patients do. There are a lot of ifs and buts in this particular trial, but I think what message we need to take away in the Indian context is selected patients of pancreatic necrosis can be managed very well with endoscopy, and selected patients have to go for surgery. So there is a sort of a gray area in between where surgery or endoscopy. And the ones who are very well encapsulated necrosis, suitably located behind the stomach, they probably do better with the endoscopy. But with a large amount of necrosis, very big collections, multiple location of the collection, there is no option but to do surgery.
So this tension trial has shown that primary endpoint between two groups is not statistically different and mortality do not differ between two groups. Then these patients were again followed up in next trial, which is extension, and again the results were similar. There is no difference in mortality and major complication, and endoscopy. However, endoscopic step-up has fewer rates of pancreatocutaneous fistula. That's obvious. The surgery is done from the outside. That's why there is more chance of external pancreatic fistula and fewer reintervention after the initial 6 months of follow-up. But what I want all of you to understand here is 19 centers for 5 years screened more than 400 patients and only 98 patients were enrolled. So this trial's results may not be applicable to 75% of patients what we are seeing. That is because this study has included only those patients whom endoscopy is also possible and surgery is also possible, and majority of other patients where either endoscopy is not possible or either surgery is not possible, so they can't randomize them. So you need to understand this thing. So this is what both of our panelists were saying. If the collection is in close proximity with intestine, endoscopic therapy can be better along with endoscopic necrosectomy. If there is deep extension into paracolic gutters, endoscopic therapy plus PCD, if required surgical minimally invasive retropancreatic debridement. And if the collection is distant from duodenum and you are not able to see by endosonography, you can directly go ahead with PCD, and if the surgical step of approach, PCD followed by necrosectomy. Along with all maximum supportive care from critical care group and nutritional point of view, that should be considered. Okay, and ultimately those patients who don't improve can go ahead with surgical necrosectomy. So coming to the endoscopic step-up approach, this is published by AIG, in which more than 600 patients of pancreatic fluid collections were enrolled, and 200 odd patients underwent endoscopic drainage with metal stent. And surprisingly, with this protocol, 75% of patients don't require any endoscopic necrosectomy or further reintervention for walled-off necrosis, and remaining 25% required step-up approach, and around 5 to 10% patient usually required PCD or surgery in the follow-up. So when we are considering endoscopy-related drainage, there is option of putting metal stent and the plastic stent. So many studies have shown that at 1 month or 6 months, plastic stent and metal stent are equal. But they missed one very important point, which we have done this study in AIG, in which we compared Nagi SEMS and plastic stent for walled-off necrosis, in which 46 patients were randomized into 2 groups. At 1 month, the clinical success is equal in both the groups. However, this clinical success comes with a cost of reintervention, and the patients who underwent walled-off necrosis drainage with plastic stent required multiple reintervention to achieve that clinical success, because you won't be waiting for 1 month to have a clinical success. You will go ahead and try to achieve clinical success. So coming to the next part, the spectrum of minimally invasive intervention, and out of them the first thing, as we discuss in surgical step of approach, is PCD. I like Dr. Vivek to put a light about this. What are the PCD options, and what are the things that he considered during placement of percutaneous drainage?
First of all, the advantage of the percutaneous drainage, most of the patients on pancreatitis are very sick. They cannot be transferred out of the ICU. So you definitely require bedside procedure. So any percutaneous procedure, USG guidance is always feasible in any of the patient, especially the bedridden patient. Second thing, it is done under local anesthesia. So GA anesthesia, GA fitness is not required at all. Then, if the patient is very sick, not resolving counts, collection is infected, patient is in sepsis or organ failure, we recommend to put as early as possible and as big as possible. So typically we go ahead with the 14 or 16 French pigtail catheter. Then let it drain. Regular flushing of the catheter is always required to prevent the debris clogging the pores of the pigtail. Despite of the pigtail placement, if the patient's symptoms are not improved, so immediately we have to do the repeat imaging in the form of either ultrasound or CT to see any new collection has happened or any malpositioning of the catheter has happened. Because if there is a catheter in malposition, we have to reposition the catheter, and if new collections develop, we have to put one more catheter. So technically speaking, there is no limit to how many drains to be put. So if patient has 4 or 5 different collections, we have to put 4 or 5 different drains. So that is always there. And if the catheter is getting clogged regularly, so we can always put a bigger catheter. And lumen of the catheter, there is no limit. With currently available hardware, we have 28 French, up to 28 French drainage catheter available. So effectively that can give a port for the endoscopic necrosectomy. They can pass pediatric or probably adult scope through it and do necrosectomy also.
So this particular one, if there is very thick necrosum or pus coming, we can put in what is called as a kissing catheter. If you can see, there are 2 catheters in close proximity. One is used for the instilling some irrigation fluid, and the other one functions as the outlet for that.
Yes. So next step is invasive surgical options. So Dr. Aditya, what are the invasive surgical options for these patients?
So we have, coming to minimally invasive surgery for pancreatic necrosis, we have basically broadly 2 surgeries. That is, one is a video-assisted retroperitoneal debridement, wherein we go into the retroperitoneum without exposing the peritoneal cavity. If the patient has a collection which is localized mainly to one side, that is largely to the left side, that is the you can see the middle patient, we can use the video-assisted retroperitoneal debridement. If the collection is localized in the retrogastric region, we can go transgastric, that is open the anterior wall of the stomach, localize the collection through the posterior wall, and make a communication between the stomach and the necrotic cavity. So that is transgastric necrosectomy. Video assisted, we already used the tract placed by the percutaneous drain. So here comes the importance of a teamwork between the intervention radiologist and the surgeon, because the pigtail has to be in the subcostal region, it has to be as laterally as possible so that we don't go through the peritoneum. And this is what is a prerequisite. We need a collection which is largely into the lesser sac or to the left side, and paracolic collections can be done, but if there is very deep extension, it is difficult. The last picture shows the status after the ward. You can see that the entire cavity looks clean and it has collapsed around the drain which is placed.
Yes. So what are contraindication and disadvantages of these procedures?
So contraindication, one, if there is an associated intraperitoneal pathology, like sometimes these patients have a colonic fistula, sometimes there is a bowel gangrene associated with pancreatitis, or there is a gallbladder pathology, we have to go into the peritoneum. So VARD will not work in such cases, you have to go for a laparotomy. The second, very extensive necrosis, multiple locations, we can't just deal with one location at a time, we have to tackle all of them, and that's why open necrosectomy might be required. The last two is like lack of specialist personnel. Obviously these procedures have to be done in a high volume center, and there has to be a very good critical care backup for us to be able to do these kind of things. And disadvantage, obviously because it is retroperitoneum, we can't go inside and see the peritoneal cavity, but we can always put in a laparoscope and do a quick examination transumbilically. It is time consuming. Obviously the access is less as compared to the open necrosectomy, but because the surgical stress and trauma is also less, we can take them up for multiple sittings. Very often it can be done even at the bedside also.
So there are two another complications associated with acute severe pancreatitis is either colonic obstruction or colonic communication and bleed because of pseudoaneurysm. It can be intracystic bleed or bleed through the ampulla, which is known as hemosuccus pancreatitis. So this is the patient who is in the 3rd week of acute severe pancreatitis, having necrotic collections, and this CT cologram is showing obstruction at the level of transverse colon. What can be the next plan for this patient, Dr. Aditya?
This would so colonic obstruction basically can happen because of two things. Either it can be in the early phase of the illness because of the inflammatory process which has involved the transverse colon, and most of the time these are transient obstructions. As the edema settles down, it does open up many times. And one late stage complication is colonic stricture, which can happen because there is a thrombosis of the vasculature which leads to the colonic ischemia. So in case there is a stricture which has formed, there is no choice but to either bypass it or to resect it. Resection is very difficult, so most of the time a bypass is what is required. And if this is an early stage obstruction, we usually wait it out and try to manage it conservatively, because going in the abdomen in the acute pancreatitis, it can be a nightmare.
What can be the absolute indication for surgery in this patient? So in early, like before 4 weeks. So you'll go ahead like.
So few of the indications to go in early. One is a bowel ischemia or bowel perforation in the early phase. Second, because of third spacing, and nowadays we are doing aggressive fluid resuscitation, so there can be an abdominal compartment syndrome. So they sometimes require a decompressive laparotomy. That is just opening up the fascia and allowing the intra-abdominal pressure to decrease. Usually in such cases we don't touch the pancreatic necrosis in the early stage.
So this is another patient who developed a sudden onset. He was discharged for 2nd week because he is improved clinically, and he came back at 4th week with increased abdominal pain with a large cyst showing intracystic bleed, and on CT angiogram we could find a pseudoaneurysm. So I'll ask Dr. Vivek to enlighten when do you suspect bleed related to pancreatitis and how we can manage it.
When there is a sudden drop of hemoglobin, obviously, and patient hemodynamical status alters in a short span of time, or you can get any blood clots within the pseudocysts. So then, and that is an indication there is some bleeding has happened probably from the gastrodenal artery, or it can be from splenic artery. So we have to do the CT angiography first as a cross-section modality to confirm the source of bleed. Even CT angiography doesn't have any bleeder, there should be a low threshold for the DSA, because some small bleeds will not be picked on the CT angiography, but DSA has a high resolution. DSA is not only diagnostic but it's a therapeutic modality. You can, if you locate the pseudoaneurysm in the same sitting under local anesthesia, you can go ahead and close the bleeder either by putting multiple coils, or you can inject some liquid embolization like H1
So this patient had a splenic artery pseudoaneurysm which was embolized with coil. So this is one of our experience we published in JGH of more than 100 patients who presented as hemosuccus pancreaticus. Coming to the second part, the majority of most common causes of acute pancreatitis are either alcohol or gallstone related pancreatitis. And the patients who develop gallstone related pancreatitis are usually because of there is a seepage of stones into CBD, and for that we have specific endoscopic therapy which is ERCP. So I'll ask Dr. Varun what is his take on performing ERCP in patients with acute pancreatitis.
ERCP do perform in biliary pancreatitis when there is evidenced cholangitis. When there is pain, fever, jaundice, along with ultrasonic LFT, and when there is demonstrable biliary obstruction, then only we do ERCP. When there is biliary mild or severe biliary pancreatitis without cholangitis, we tend not to do ERCP. There is this study they had done ERCP, urgent ERCP with sphincterotomy or versus conservative treatment in patients with cholestasis. Outcome was very poor or bad in patients who had conservative treatment. So ERCP definitely saves the patient when there is proven cholangitis in biliary pancreatitis.
So the patient presenting with acute biliary pancreatitis with acute cholangitis can be the indication for urgent ERCP. All other patients can be managed conservatively, and ERCP can be performed electively. So another complication of acute pancreatitis is, suppose we drained with PCD but we're not able to remove the PCD, that's persistent PCD outcomes, or pancreatic ascites and pancreatopleural fistula. This is one of the patient who had a large necrotic collection with air within the wall of necrosis, and he underwent the PCD placement. I'll ask Dr. Varun to tell us the management of pancreatic leaks which present as persistent PCD outcome or as a pancreatic ascites or pleural fistula.
As I said earlier, this pancreatic leak or fistula is very difficult to manage. As we can see, there is a drain inside, collection is reduced, still patient has ascites. So in that case, drug treatment, as I told, we start somatostatin or octreotide, but definitive therapy will be PD stenting, ERCP and pancreatic stenting, putting a stent into the PD so that continuity can be restored and juice can be drained into the duodenum.
So for this particular patient, we could breach the pancreatic leak and subsequently we could remove the PCD, but there are chances that we could not reach up to the leak and we may not able to place the bridging stent. In that position, I think the surgery can be a good option, which include, I think, distal.
So if there is a persistent pancreaticocutaneous or pleural fistula and the bridging has not been successful, endoscopy has basically not worked, there are multiple options, depends on how much disconnected pancreas remnant there is onto the left side. If there is a very small remnant, we can just remove that, do a distal pancreatectomy. Or if there is a significant amount of remnant, like at the neck, if it is transected, we have the entire body and tail, we can do what is called as a fistulojejunostomy. That is, you bring up a loop of the jejunum and actually dissect out the fistula tract and do anastomosis between the fistula and the jejunum. So it is a sort of internal drainage of the fistula.
Yes. So the patient presenting with acute necrotizing pancreatitis with organ failure during first day of symptoms, he should be managed with the critical care team to manage organ failure with all possible supportive care, if required tracheostomy and dialysis as per the indications. And the patients, this particular patient where we're discussing, he had multiple wounds at 4 weeks and he is persistently having fever, not able to control with antibiotics and supportive care. So they underwent a multimodality approach in which the PCD was placed first and US drainage was done at the same day so that we can get a dual drainage. This is the, sorry, you can after 72 hours, this patient has not improved and collection was not able to decrease, and patient was persistently having fever and the worsening organ failure requiring higher inotropes, dual inotropes. So we asked our surgical colleagues to go ahead with surgical debridement and eventually patient improved. So this is the one of the therapy where team works help us. Coming to the last part, which is prevention of pancreatitis. So there are three or four main components to prevent pancreatitis. One of them is patient should undergo cholecystectomy. If is acute mild attack of pancreatitis, patient can undergo cholecystectomy within same admission. If it is severe, then it should be elective or during the drainage of necrosis, surgical drainage. a patient should be counseled for de-addiction both for alcohol and smoking. Smoking independently associated with risk of acute pancreatitis, and those patients who are having hyperglycemia should be sought out for hyperparathyroidism, adenoma or hyperplasia and can undergo parathyroid surgery, and patients with hypertriglyceridemia or those who develop pancreatitis because of particular drugs, these drugs should be avoided. So to conclude, infected pancreatic necrosis management and acute pancreatitis management require more and more aggressive therapy along with lesser and lesser invasive therapies which include PCD, endoscopic drainage and minimally invasive surgical drainages. Minimally invasive approaches improve majority of patients. Few patients still may require or land up into mortality. But ultimately, what matters is the role of multidisciplinary team to become to get a good success in managing acute severe pancreatitis with organ failures and infected ones. Thank you. I thank all of my panelists, and I like to invite all of you for, if you are dealing with obesity and metabolic diseases, this is the first International Diabetes and Metabolic Disease Summit will be held in AIG in October end. I invite all of you. Thank you.
That was an excellent discussion, Dr. Nitin Jagtap and all the panelists. If we have some questions from the audience, we may take about 2 questions, not more. Yes, sir.
We are not entering the, if we require to enter the peritoneum, the laparoscopy is totally out, or I didn't find any mention of that.
Minimally invasive, there is a definite role, sir. If the, as he mentioned, if the cyst is abutting the stomach,
no, that is endoscopic. I'm talking about
laparoscopic. Yes, that's what
can be done laparoscopic.
Can be done.
So practically speaking, endoscopic cystogastro is good if the collection has a predominantly liquid component. If it is all packed solid necrotic debris, we can go in with a laparoscope, do the exact same thing laparoscopically, open the anterior wall of the stomach, make a communication between the posterior wall and the cyst, debride all that cavity, get it out into a pack in the peritoneal, and then remove it through one of the ports. So it can be done laparoscopically.
Even in the tail regions, if there are collections, we can do a cystojejunectomy instead of doing a cystogastrostomy. So these are the 2 options. Only gray area is if the collection is near the duodenum, then it becomes problematic because endoscope cannot effectively drain it and neither surgical drainage. Then the open procedure comes into picture. So I think for the benefit of the audience, what 3 important points the panelists have made is try to delay the CT unless there is an cause like biliary pancreatitis as much as possible. Starting early feeds after 72 hours. Minimal invasive, try to delay the intervention as much as possible, and if at all minimal intervention, be it radiological or surgical. Only one question I have to Prashant and the rest of the panelists. We always say that avoid antibiotics in pancreatitis, but patient having SIRS and you're not giving antibiotics, it sounds, we are pressed to start. So what is the practical thing that you all are doing? Because we per se start antibiotics if there is evidence of SIRS.
Kedar, first we have to move on from the concept that antibiotic is the answer to everything. In pancreatitis, the SIRS happens and it is quite severe. So initial period there is no infection. So you should not treat that SIRS with the infection. But there are around 15 to 20% of the patient who might have infection with the pancreatitis. Like we mentioned, the cholangitis is the commonest cause of pancreatitis. So in that scenarios, we require antibiotic. Again, these patients, if there is alcoholic, UTI, repeated admissions, these patients only will require the antibiotics. When we are deciding about the antibiotics, the next question again becomes which one. So the antibiotic should be of choice which has got good penetration to the pancreatic tissue. That is usually in the later part of the acute severe pancreatitis.
I think the reality is that we are, as a whole, we are all quite guilty of misusing antibiotics in acute pancreatitis. There was a very thought-provoking study from my parent institute, PGI, where we had we had taken all the history of patients referred from outside as well as within the institute. And by the time these patients come for surgical intervention in the 4th or 5th week of illness, they have received, so the median number of antibiotics which had been used was 6,
the number of antibiotics, and they had a median of 4 antibiotic classes which had been used during the entire hospital stay. So if this is not promoting antibiotic resistance, I don't know what is.
Kedar, now we have endoscopic ultrasounds in almost all the institutes, so it's quite easy for us to go in and aspirate and send the cultures. And like Dr. Nitin said, Procal is really very good. So you have a Procal which is more than probably around 6, that's the time that the patient is in severe sepsis. And cholangitis is easy to pick up. You have stones, that's easy to pick up on an imaging modality. So I don't think you should be using antibiotics.
Okay, thank you. May I now request Dr. Rajuvariani sir, President, to come on the dais to felicitate all the panelists and the moderator, Dr. Jagtap sir. Please come on. I also request Dr. Dadasaheb Maindad to join for the felicitation. Dr. Jagtap sir, please come.
वायरलेस सीन बघावं लागतं माहिती आहे का स्टुडंटसाठी वायरलेस बघावं लागतं.
Dr. Nitin Jagtap. Next, Dr. Prasant Jedge sir. Dr. Vivek Murumkar. Dr. Aditya Kulkarni. And Dr. Varun Khandagre. We have slight change in plan of the next speaker. So I would like to invite Dr. Sahil Rasne for his talk about management of chronic pancreatitis. Dr. Sahil Rasne is a gastroenterologist practicing at Ruby Hall Clinic, Pune.
To chair the session, may I request Dr. Jagtap sir, Jagtap, he is here. Dr. Rupesh Lunkar sir and Dr. J.K. Banerjee sir, who is professor and HOD GI surgery at Bharati Vidyapith. Dr. Lunkar sir is the assistant professor in gastroenterology, Bharati Vidyapith. And Dr. Jagtap sir is physician with SAISNI. As Dr. Kedar Patil has already said, Dr. Sahil Rasne is a gastroenterologist at KEM at Ruby Hall. He is specialist in motility disorders of gut and advanced endoscopic therapy. He has multiple publications in major journals and he has to catch a flight, so we have just changed the sequence. So over to you.
So at the onset, I would like to thank Dr. Dadasaheb Maindad for this opportunity. He has given an extensive topic. I don't know how to finish this in 20 minutes, but I'll try and make some justice to the topic. So I'll be talking on chronic pancreatitis and its management. So chronic pancreatitis is a progressive fibroinflammatory syndrome which is caused by a variety of etiological factors. The most common being alcohol, and there are other etiologies like idiopathic, genetic predispositions, and autoimmunity. There is permanent and irreversible damage to the pancreas with histological evidence of chronic inflammation, fibrosis, and the most important thing is there is destruction of exocrine and endocrine tissues, that is the acinar cells and the islets of Langerhans. The prevalence as per various data sources is about 0 to 0.4 to 5% in autopsy reports, and in retrospective studies about 3 to 9 in 1 lakh population. And the most important cause in all of this is about alcohol abuse, which counts to about 2/3 of the entire cases of chronic pancreatitis. We rarely have data from India, but thankfully we have some data regarding chronic pancreatitis in India. So alcohol again predominates in India over about 40 to 50% of all the cases. There is a slight difference in North and South India, where tropical pancreatitis, which is more commonly because of antioxidant deficiencies which occur during childhood, is one of the major causes of pancreatitis in South India. So the clinical features, as like the rest of the world, mostly patients have pain. But in South India, where there is more of, like I said, antioxidant deficiencies, these patients predominantly have malabsorptions more common than in North India, and diabetes, which is more common. So the pathophysiology of chronic pancreatitis is not really understood, but alcoholic pancreatitis being the most common, the most attention it has received over the years. But we still don't know why only 10% of heavy alcoholics develop chronic pancreatitis. Because this is the question that the patient will come and ask that, me and my friends, we are having same amount of alcohol, but I have pancreatitis and he doesn't. So we don't know what that causes. So what is the pathophysiology? So alcohol is basically metabolized by both liver and pancreas. In the liver, the end product is acetaldehyde, and while in pancreas, an alternative pathway produces something called as fatty acid ethanol esters. These have a direct injurious effect on pancreatic acinar cells. Basically what these do is stimulate the pancreatic stellate cells, which leads to fibrosis. So when activated, these pancreatic stellate cells assumes an stellate or a myofibroblastic appearance and express smooth muscle actin and lose their lipid droplets. So activation of this pancreatic stellate cells is the most important part in the entire pathophysiology of pancreatitis. And activation can occur because of two things. It can be because of a direct association of alcohol and its metabolites, or it can be due to indirectly by cytokinin surge that occurs because of cellular necrosis. Now, ductal obstruction hypothesis is very, very important. So chronic alcohol use basically leads to protein-rich pancreatic juice, which is low in volume and bicarb. This leads to formation of protein precipitates and forms plugs. These plugs are ductal stones which cause obstruction of the duct and cause parenchymal damage. But what is important to note is that not only alcoholics but also tropical, hereditary and idiopathic pancreatitis can also have pancreatic duct. So just because the presence of stones doesn't mean it's just alcohol-induced chronic pancreatitis. So toxic metabolites focuses primarily, we are focused on alcohol and its metabolites because I've said that most commonly alcohol is the cause. They cause direct injuries to the acinar and the ductal cells. It leads to increased membrane lipid peroxidation and free radical production. This activates, like I said, stellate cells and begins to secrete extracellular matrix and produce fibrosis. Now, repeated attacks of acute pancreatitis with cellular necrosis or apoptosis eventually leads to development of chronic pancreatitis as healing process replaces necrotic tissues with fibrosis. Idiopathic pancreatitis is seen in about 10 to 30% of all cases. There are basically two forms. So the early onset form is seen in late 20s or early 30s, while the late form can be seen as late as 6th and 7th decade of life. I'll skip this slide. So chronic pancreatitis has usually two phases. One is the early phase, where the patient usually seeks help for pain, recurrent episodes of pancreatitis and complications. So these recurrent episodes, we usually call them acute flares of a chronic pancreatitis, and in advanced phase there are exocrine and endocrine insufficiencies for which the patient might come to us. So the abdominal pain, which is the predominant symptom, patients will usually come to us with epigastric pain with radiation to back. This is usually a deep, boring, penetrating pain associated with nausea and vomiting. This is usually relieved by sitting forward or leaning forward. Pain has a highly variable clinical presentation. Some patients may have only a mild pain, and some patients have chronic, severe pains which don't sort of respond to many medical therapies. Steatorrhea is again one of the important clinical presentations. Steatorrhea doesn't occur until pancreatic lipase secretion is reduced to less than 10% of the maximum output. Steatorrhea is therefore a feature of far advanced chronic pancreatitis in which most of the SNR cells have either been injured or destroyed. Affected patients may present with diarrhea, weight loss, and some patients may also note bulky, foul-smelling stools. Diabetes mellitus is an endocrine insufficiency which occurs in long-standing chronic pancreatitis, usually seen post-pancreatic resections and also seen in tropical pancreatitis. So this tropical pancreatitis was discovered by one of our Indian doctors, Dr. Mohan, who is based in Chennai. So islet cells appear to be relatively resistant to the destruction in chronic pancreatitis. About half of the patients with chronic pancreatitis who develop diabetes will require insulin. Unlike type 1 diabetes mellitus patients, insulin producing beta cells and glucagon producing alpha cells are injured. Ultimately, about 40 to 80% of patients with chronic pancreatitis have diabetes on long-term follow-up. During an attack, patients may assume a characteristic position, like we said, leaning forward. They may have tenderness, fullness, or a mass which can be palpated in the epigastrium, which usually suggests a pseudocyst or an inflammatory mass. Jaundice may be present because of a coexisting alcoholic liver disease, which is quite rare, which affects less than 5% of patients. Or it can be most likely because of ductal compression, which occurs because of an inflammatory mass. Or rarely, less than 5% of patients with chronic pancreatitis may develop something called as a cancer of the pancreas, which usually affects the head of the pancreas. A palpable spleen may occur because of two things. There can be a septic thrombosis of the splenic vein, or there can also be coexistent portal hypertension due to coexisting chronic liver disease. So diagnosis is important because we need to find out the etiology also, because your management changes as per that. We have diagnostic tests which detect the abnormality of pancreatic function and detect the abnormalities of pancreatic structure. So like I said, why it is important to find the etiology is because we all know that steroids causes pancreatitis, but in autoimmune pancreatitis, that is the treatment of choice. If we know that the patient has stricture stone, we can give patients endoscopic or surgical therapy. The most important is if we know the etiology of being alcohol, we can talk to the patient, enter them in a counseling session, and we can tell him to stop alcohol use. And of course, hereditary pancreatitis, that the next generation is not affected by. So how do we diagnose chronic pancreatitis? So the simplest way to do it is ultrasound. If it is positive, it shows atrophic pancreas. If it shows ductal dilatation, if it shows stone, then you know that the patient has chronic pancreatitis. We can also move on to doing something called a CT, but we have to specifically ask for a CT with pancreatic protocol. An MRI with MRCP helps quite a lot. And endoscopic ultrasound is very good to pick up early chronic pancreatitis. If all these tests are negative and there's still a suspicion, then we can do pancreatic exocrine functional test, and then we can diagnose the patient to have chronic pancreatitis. So what are these different functional tests? Most of them are not available, but are available in research labs. So we can do a direct hormonal stimulation test with secretin or cholecystokinin. Fecal elasticity is now available, which we can do. Fecal chymotrypsin, fecal fat estimation, blood glucose levels, and for the structure we can do an endoscopic ultrasound, where an ultrasound probe is attached to the end of the scope, and we can go very near to the pancreas and have a look at the pancreas. We can also do a CT and an MRI for these patients. So what do we look for chronic pancreatitis and ultrasound. So we look for pancreatic duct dilatations. We also look for main pancreatic duct irregularity. We look for increased ecotexture of the duct wall, focal necrosis, and irregular contour of the head. We also look for strictures and stones, of course. So, like I said, an ultrasound is the initial imaging study, followed by endoscopic ultrasound. For the time, I'll skip this, sorry. So, the imaging modalities, like I said, MRCP and EUS have almost got about 90% of specificity and sensitivity to diagnose chronic pancreatitis. ERCP was used initially, but it is no longer a diagnostic test because MRCP gives us most of what we need. So the complications that we come across in chronic pancreatitis are pseudocysts, bleeding, CVD obstruction, pseudoaneurysms, duodenal obstructions, pancreatic fistulas, and of course endo and exocrine insufficiencies. So we come on to management of chronic pancreatitis. So if we know the complications like pseudocyst, duodenal obstruction, gastroparesis or CVD obstruction, we can treat them accordingly. We can give them analgesics. To decrease the intrapancreatic pressures, we can use pancreatic supplements and we can relieve the ductal obstructions. To modify the neural transmissions, there are now very good modalities where we can do celiac plexus blocks in these patients. I think Amol had touched on this earlier. Then we can remove pancreatic parenchyma by head resection surgeries such as Whipple's bridge and Fraze procedure. And very rarely do we do pancreatic total pancreatectomy. So management of abdominal pain being the most common and most debilitating symptom, the initial evaluation of pain should focus on identifying associated conditions for which specific therapy exists. Very important thing. So these conditions can include, like I said, the pancreatic pseudocyst, duodenal compression, superimposed pancreatic carcinomas. These are present in about 5% of patients and gastroparesis. So the pain management would be analgesia, antioxidants, pancreatic enzyme therapy. Then endoscopic therapies would be pancreatic duct sphincterotomy, stent placement, ductal stone removal, and combined endoscopic therapies. So most patients will require analgesia. Half of the patients will require opioid. The risk of addiction is like any other chronic condition, so it's usually less than 20%. But the red flags that we need to look at is previous history of drug abuse. Patients who have alcoholic chronic pancreatitis do develop addictions, and also we have to be careful with history of smoking because these are the patients who are liable to develop addictions. So how do we treat pain? So recurrent pains, NSAIDs and short-term opioids. So if it's a ductal obstruction, then ductal decompression, which can be done by medical or surgical gastroenterologist. For post-ductal clearance, if the pain still persists or the patient has a small ductal disease, we can use methionine-containing antioxidants. If there is inadequate response, then prostaglandins and SSRIs can be used. If the patient has stricture, stone, local complications or cancer, we have to treat it accordingly. So these are the various drugs that we can use. So paracetamol, tramadol, buprenorphine, morphines can be used. We have to go from less potent to more potent drugs. Antioxidant micronutrients are primary aim of antioxidant therapy is to supply methyl and thiol moieties for transsulfuration pathway. These are essential for protection against reactive oxygen species mediated electrophilic stress. There are different studies that have been published which show that patients have about 30 to 40% pain abolishment following these supplementations. Pancreatic enzymes have often been used in control of chronic pancreatitis. The hypothesis is that proteases in the enzyme supplements would inhibit overstimulation of duodenal cholecystokinin receptors, which will in turn inhibit the food-induced feedback loop, thereby putting pancreas to rest. So, review of about 10 RCTs involving 360 patients found equivocal pain relief, fecal fat excretion, and improvement in quality of life in pooled analysis. The two individual trials that used non-enteric coated preparation showed significant improvement in pain. So what are the different endoscopic therapies for pain? So aim is, if there are stones, to remove the stones, strictures to dilate those strictures, and of course celiac plexus blocks. So ductal anatomy that is most amenable to endoscopic therapies is a dilated MPD, which is more than about 5 to 6 millimeters, and an obstruction at the head, usually a stricture at the genome. Multiple stones, impacted stones, distal body stones are not amenable to endoscopic therapies because we can't reach to the distal body of stone, distal body, unless we have 5 scopes. Decompression includes pancreatic and biliary splenectomies, stricture dilatations and stenting, stone extractions, and lithotripsy. So endoscopic decrease the intraductal pressures and thereby decreasing the pain. ESWL is usually applied if the patient has large stones, multiple stones, followed by their extraction by ERCPs. There have been studies which have published which also say that ESWL without ERCPs also work, but there are doubts on that. So neurolysis, endoscopic guided neuroblocks and neurolysis is safer, non-painful to the patient, and are more effective than CT guided neuroblocks. Now we can do these neuroblocks by delivering bupivacaine and corticosteroids as a sandwich. We can also do neurolysis by absolute alcohol, but these are usually reserved only for patients with suspected carcinomas. Local surgical interventions are done if the patient has duodenal obstruction or if patient is suspected to have carcinoma which cannot be ruled out by preoperative evaluations. So the various surgical interventions are lateral pancreaticojejunostomy or a modified Peugeot operations. These are most commonly done. Incision is usually up to the tail of the pancreas. Stones are removed and the strictures are excised in this procedure. This requires the PD to be dilated to at least about 6 mm. The pain relief immediately post-procedure is only in 80% of patients. At a 5-year follow-up, 50% of patients will still have pain. Surgical procedures have local head resections because that is where the hypertension is for the pancreas, and they are combined with PD drainage. So these are Whipple's, Fraze and Berger's procedures. Rarely disease is restricted to the tail, and in these cases we can offer the patient something called as distal pancreatectomy. Rarely total pancreatectomy is done when all other procedures have failed, but the relief in these patients is also only 66%. So this indicates that there is a complex extra pancreatic mechanism for pain. So management of steatorrhea, fat maldigestion is a principal clinical problem, and it has been estimated that the amount of lipase delivered to the intestine with each meal should be sufficient to eliminate the steatorrhea. If a non-enteric coated preparations are chosen, concomitant suppression with gastric acid with H2 blockers or PPIs is necessary. There are several explanations for failure of enzyme therapy for steatorrhea, the most common being inadequate dose, generally due to patients' non-compliance with the number of pills that must be taken. There are two things for this: the amount of pills and also the cost of the pills is just too high. Diabetes is an independent predictor of mortality in patients with chronic pancreatitis. Ketoacidosis, though, is unusual. Insulin is often needed, and patients with chronic pancreatitis tend to have lower insulin requirements. So, pancreatic exocrine insufficiency, the most common cause is, of course, chronic pancreatitis. The Western world has attributed this to alcohol abuse, pancreatic duct obstructions, genetic mutations, and metabolic disorders such as hypertriglyceridemias and hypercalcemias. So pancreatic exocrine insufficiency, the prevalence rate is very varied from 22 to 94 depending upon which trial you pick up. The rate of pancreatic exocrine insufficiency in patients with CP is dependent upon the severity of disease and the length of the time since diagnosis. The clinical features are usually maldigestion, and patients can present to you with malnutrition, Fat maldigestion is characteristically seen as steatorrhea. This develops earlier in the course of CP. Protein and carbohydrate maldigestions can be present. Patients can also present to you with loss of bone mineral density and bone mineral content. The standard treatment for pancreatic and exocrine insufficiency due to chronic pancreatitis is an individualized dose of pancreatic enzyme supplementation. This is according to degree of maldigestion and fat content in the diet. The dose recommendations are generally provided in units per meal. So usually the starting dose should be somewhere around 25,000 to 40,000 lipase units, which may be increased to 75,000 to 85,000. So normally the tablets that you get, there are various companies that provide it, such as Creon, Pan, lipase and all. So usually when they mention 25,000, they are talking about lipase. For the in-between snacks, half of the main meal dose is recommended. So we usually end up giving the patient about 10,000 of lipase in the afternoon. So how do you manage the pancreatic exocrine insufficiency? So increase fat content along with pancreatic enzymes improve pancreatic malabsorption. Medium chain triglycerides such as fatty acids that vary from 6 to 12 carbons in length could replace the dietary fat in non-compensable steatorrhea and weight loss as more readily hydrolyzed by pancreatic lipase. Fiber-enriched diet should not be given. These can inhibit pancreatic enzymes in vitro and also in vivo. Short-term ingestion leads to increased fecal fat excretion, probably due to decreased fat absorption from intestines. Long-term ingestion of dietary fibers can result in increased pancreatic lipase secretions in healthy subjects. Fiber could delay development of overt pancreatic enzyme insufficiency in chronic pancreatitis without malabsorption, but you need further studies for this. Alcohol abstinence is an absolute must. So requirement of pancreatic preparations to treat malabsorption, sufficient enzymes into duodenum which will achieve at least 10% of normal concentration and delivery of enzymes postprandially, should have shown clinical improvement of steatorrhea. Simultaneous gastric emptying of pancreatic enzymes and food. Under optimal conditions, lipase must be taken with each meal. So if the patient has pain predominant disease, then high protease content of enzyme should be taken. If patient has malabsorption which is more predominant, then high lipase and low proteases. If the patient has both pain and malabsorption, then high lipase and trypsin should be used. I think so. The essential conditions, so criteria for good pancreatic enzyme therapy is the essential conditions for their use are non-toxic, well tolerated, no undesirable side effects. pH should be optimum and pH stability with a range of 3 to 7 should be there. They should be stable towards pepsin, intestinal and pancreatic proteases, and they should induce release of fragments from the food constituents, either absorbed immediately or can be degraded to absorbable lower molecular weight. So which patients should be treated with pancreatic enzyme supplements? Patients who have symptoms associated with steatorrhea, patients who are losing weight, patients who have diarrhea or dyspeptic symptoms, and combination of 2 or more of these symptoms is apparent. So up to 70% of patients with chronic pancreatitis related maldigestion have abnormally low nutritional parameters. Usually they have low serum levels of fat soluble vitamins. Malnutrition is associated with severe complications and high risk of death. Enzyme substitution therapy is indicated in every patient with pancreatic enzyme malabsorption. So what is the required dosage of lipase per meal? So in order to reduce the steatorrhea to a tolerable range, about 25 to 40,000 of lipase per meal should be given in a pH sensitive pancreatic microspheres. High lipase, like we had said before, can be used. For the lack of time, I'll skip these slides. So yeah, so I think I'll conclude here. I'm so sorry I have to leave. Thank you. Any questions?
on chronic pancreatitis, including the pancreatic enzyme replacement therapy, pathogenesis and all. Very good lecture.
Thank you.
I'll, you are like trying to catch your flight, but I'll still ask you one question. Like when we were students, we were told that a patient of chronic pancreatitis must earn his surgery. That means you delay his surgery till he begs for it. That used to be the catch line. If he begs for it, you don't operate on it. But is the concept now changing? Do you recommend early surgery for a better benefit and better recovery?
No, sir. As in, I would not recommend an early surgery because even with surgery, even with patients who have pancreatic stones, strictures which have been proven, the pain relief is only in about 60 to 80% of patients. At the end of 5 years, anyways, the response to that surgery goes down to about 50%. So, like you said, the old still stands true where the patient has to earn for it. But we have fantastic endoscopic methods now. So if there is a single stricture, a single stone, we can go in and endoscopically sort of modulate that stricture. We can do ERCPs for that. And we have got fantastic therapies which are not so interventional, which cannot.
In this case, I was referring to the ESCAPE trial.
Yeah.
It has shown that it has early surgery has got better
preservation
of the pancreatic parenchyma.
Okay, so but in that particular trial, the patient selection was different. So you had patients with multiple strictures. You had
those who require surgery.
Yeah, so you have to be very specific in picking up patients for surgery. Rather, you can't do it for everyone. Like I said, that there are different surgeries for different areas of pancreas that are involved. So you have to be very specific. It has to be patient driven. You can't just recommend surgeries for everyone.
Patient who is having single stricture, small stone volume, particularly in head and body, these can be very well tackled with endoscopic therapy plus ESWL. Patient having multiple stones throughout the pancreatic duct, multiple strictures associated with tumor, suspected malignancy, these patients should go for surgery.
Small duct disease, again, to add to that surgical list.
Thank you, Rasli sir, for a wonderful lecture. And really will help physicians like us to treat the pancreatitis very well. Also, thank you, Dr. Maindad sir, for giving me opportunity for a chairperson and also organizing such a wonderful event. Thank you.
Thank you, Dr. Rasne. May I request our President, Dr. Raju Variani sir, our past President and Trustee, Dr. Dilip Sarada sir, to felicitate Dr. Rasne. Dr. Maindad sir, you also join. Thank you all. We'll have now lunch break. Only for 30 minutes, sharp at 2 o'clock we start the post-lunch session.